like I know
All right, everybody. It's 6 o'clock. We're going to try and get started closer to on time and get finished closer to on time if we can. As the weeks go on, remember that. Try to get in a little bit early if you can. Everybody seems to want to jump in right at 6 o'clock, and it causes a backlog. So if you think about it, try to get on just a few minutes earlier. First of all, tonight I want to thank Joe for joining us again. Joe Mistovich from Youngstown State University. As always, Larry Monero is essential to this program. Really keeps it ticking. Tonight we're going to have Peggy Higgins from Trumbull Regional Medical Center. She's our trauma director. And then after that, myself on fluid resuscitation. That should be pretty exciting. As COVID continues to really give us fits around here, once again, I want to express my condolences or my prayers to any other EMS family out there who is suffering loss or illness. I know that we all are. We're all in the throes of this. I know our hospital's been pretty well overwhelmed. I'm sure a lot of other people's have. I appreciate EMS's patience and cooperation in trying to deal with this. It's not always easy. I know that you've gotten some long waits, but I appreciate your patience in doing what's best for your patient. With all the doom and gloom, I think that EMS got a good news, bad news situation today. It was nice to see it was scary on the news to see that a helicopter carrying a medical helicopter carrying a baby crashed in the middle of a city, but everybody got out alive and unhurt, and that's pretty great. So none the worse for wear for crashing into a neighborhood. So that's a great thing. So after that, let's count our blessings and say hi to Joe. Joe's going to be talking to us about central nervous system injuries tonight. I'm looking forward to it. Take it away, Joe.
Thanks, Matt. All right, so let's see. Let me see if I can do this here. All right, are you guys seeing my screen now or no?
Nope.
Nope. All right, let me try this again. Oh, share tray. Open share tray. Why is that not? How about now?
Hold on. Nope, not yet. Just you. Just your beautiful face.
Damn it, Larry. Come on. Okay, searching presentations. I can see Matt, join conversation. See, I don't think this, I don't think this is my, on the bottom here. I don't think this is my stuff here. I wonder, no, that is my stuff. Searching presentations. So why?
There you go, Joe.
All right. Okay. I'll get this by the time we end, Larry, you know?
Just make sure you take your air step next time.
Oh, Larry, you're still an asshole. Seriously, honest to God. Wow. You know, I was going to say something nice about you too, but you know, forget that. All right.
You know, the temperature is cold enough for that, so.
All right. Well, welcome everybody. I'm glad to be back on. I hate this camera because when I put my head down, I notice how bald I am. Jesus. You know, I didn't think I was that bald, but anyways, so what we're going to talk about tonight is spinal injury and spine motion restriction. You know, it's kind of interesting the number of people that still practice the old, you know, spinal mobilization, which, you know, I have the research in here. I'll point out to you why it shouldn't be done and so forth. And, you know, I like to say that Trumbull Memorial Hospital actually took one of the positions very early on with Matt Ozanich and developed a protocol very early on following evidence-based medicine. It started to practice just lost my thought. I looked on my watch. I got a text. But an evidence-based practice on doing the new spine motion restriction. And again, I'll point out right now, the reason why they don't call it spinal mobilization, because what they found is it is impossible to immobilize the spine. The only way the spine could be immobilized is if you put a patient in concrete and let him dry, and then the spine would be considered immobilized. So it was actually a deceiving term to begin with, because there's nothing we can do that we could immobilize the spine. And we'll go through, you know, I'm going to go through this. One thing I'm going to say is that, you know, by the time I get done with this lecture, I hope that you're going to walk away with two things. One, you're going to have a really good understanding of your clinical assessment. That's my goal tonight, that you're going to actually look at your assessment of a potentially vertebral or spinal cord injured patient differently in the sense that I think you're going to feel a lot more confident and comfortable in ruling in, because we've changed ruling out spinal cord injuries and vertebral injuries to ruling in injuries, which is kind of interesting. That's an entire paradigm shift from where we were before, because we all know it. We all based our spinal mobilization on mechanism of injury, and that was the craziest thing. But I can tell you, I know call after call after call is on putting a CAT on or immobilizing a patient to a backboard saying, this patient doesn't need this. This is the craziest thing ever. But if we don't do it, we're going to get in trouble. And then we take him to the hospital. We, walk him in, and before he even walked out the curtain, you hear, and all the stuff's coming off, and it's kind of being thrown right alongside you. People just get angry and, like, I can't believe it. I did such a good job immobilizing that patient. Well, one, you weren't immobilizing them because you can't do it. And two, I mean, the physicians used a very quick assessment that actually provided them with very specific and sensitive information, whether this patient had or didn't have a potential spinal cord or vertebral injury. And so that's the main thing that I want you to leave here today with, is a different perspective on your assessment of these injuries. And the second thing is I'm going to go over, some of the techniques of doing spine motion restriction, because that's the most that we can do is spine motion restriction. So it's kind of funny because, Matt, what do you always say? You spend all this time trying to unlearn what I taught you?
No, just that everything you taught me was wrong.
Oh, so yeah, that kind of hurts my feelings a little bit, Matt, but in this case, it's absolutely the truth. It is the truth. So it is kind of funny because, I say that I have another lecture called Clinical Insights, and it's so funny because a lot of the things that we used to beat in students' heads, we turn around now and say, well, that's not really right. We say, oh, that, and if that happens, that's this and so forth. So, interesting. And especially if you are, I'll put it this way, instead of saying an old EMT, paramedic, advanced EMT, I'm going to say if you're an experienced EMT, paramedic, or advanced EMT, what were you taught about spinal cord injuries? Because I was taught this when I went through my EMT and when I went through the paramedic program too. I was taught that if a patient has a spinal cord injury, now we're talking cord, we're not talking vertebral column, we're talking cord. If they have a spinal cord injury, that patient will lose all motor function and sensory function below the level of the injury. Wherever that spinal cord lesion is, when I'm saying lesion, I'm referring to, it could be an actual tumor, it could be whatever. But in this case, I'm referring, when I say lesion, I commonly say lesion, it means that's where the actual injury is at. And we were always taught, so if you have a patient who has a spinal cord injury, below that spinal cord injury, whatever point it is, they're going to lose all motor and sensory function. And I'm assuming that a lot of you actually were taught the same thing. Well, like Matt says, I'm here to unteach you that because it's actually not the truth. So let me present these to you. What if you were to arrive on the scene and some type of trauma is involved, and some type of mechanism of injury, maybe there's blunt trauma involved, and the patient can move on the right side of their body. They can move their hand, they can move their feet, they could feel light touch on the right side of their body, but they can't feel any pain. They have an injury, they have a fracture, whatever it will be, and they can't feel any pain. But they can't move on the left side of the body. They cannot feel light touch on the left side of the body. But yet, they have pain on the left side of their body. Like, wow, that doesn't make sense, because what I was taught was anything below the level of the point of injury, they're going to lose all motor and sensory function. So this surely can't be a spinal cord injury. It has to be something different. This patient must just have an acute stress reaction. How about this one? You arrive on the scene, elderly patient, told you they fell down the steps. They greet you at the door. They walk to the door, they greet you at the door, and they say, come in. And you say, what seems to be the problem today? And they said, I was coming down the steps and I fell, and now I can't move my upper extremities. But they walked to the door to let you in. Well, how many people would say, oh, hell yeah, that's a spinal cord injury. Definitely learned that one. Again, what we were taught for the most part was anything at that lesion and below, loss of motor and sensory function. Well, now we have a patient who can move their lower extremities, but who cannot move their upper extremities. And you're going, oh, it's a spinal cord injury. And your patients go, or your partner stand there going, oh, that bullshit. There's no way that could be a spinal cord injury. How about this one? The patient can feel light touch. They can feel you touching them, but when you pinch them or you stick them with something that's, sharp, they can't feel it, but they can feel you lightly touching their hand, their foot, whatever it would be. Well, that's crazy because, God, if they can feel light touch, they can definitely feel pain. How many people make this assumption? If my patient feels me touching them, if I touch their hand, if I touch their foot. Now, when you're doing your spinal assessment, make sure that you have your patient close their eyes. Because if they're looking at you, you ever notice this, especially like in a stroke patient, they have a tendency to do this. And you say, all right, which hand am I touching? And they look over and they go, well, that's my right hand you're touching. So again, when you're doing your assessment, in your spinal cord injured or potentially spinal cord injured patient, you're doing your neuro assessment, have your patient close his or her eyes, because you don't want them to erroneously respond because they're seeing what you're doing and not because they're feeling what you're doing. But how many of you would assume that if I touched their hand on the right and I touched their hand on the left, I touched their foot on the right and I touched their foot on the left, and they could feel me lightly touching their hands and their feet, they absolutely would have the ability to feel pain, because pain obviously is a crude touch. Well, we're going to learn that's not true either. And if you've only been doing light touch and you haven't been assessing for pain in all four extremities, there's a good possibility that you've actually been missing an incomplete spinal cord injury. When you do your neuro assessment, you will find that you have to test motor function, light touch, and pain in all extremities. Okay? So making the assumption that if they could feel me touching them, I'm not going to test pain because they can obviously feel pain is a wrong assumption. So you look at spinal cord injury, it's abbreviated as SCI, spinal cord injury. And you look at the etiology, obviously the majority of spinal cord injuries are due to motor vehicle crashes, about 40%. And then the next most common is 32% are from falls, 14% from violence, it should be violence. And violence could be blunt trauma or it could be penetrating trauma too, not just blunt trauma. 9% is from sports injuries. 5% is from medical, including surgical procedures. And then there's a few extra percent in there that's from a wide variation of other things. But the most common, again, being your motor vehicle crash and your fall. Then the next most common being your violence. So that's where you're finding the majority of these injuries are occurring. Okay. Now, spinal cord injury, there's about 17,800 new cases each year in the United States. You think, well, that's not all that many. One thing I want to point out, too, this does not include those people with spinal cord injuries that end up dead at the scene. They're not counted in. These are only people that go on to survive and they have a diagnosed spinal cord injury. This is interesting. The average age is 43 years old. Back in the 70s, the average age was 29. So I'm not sure if men are getting dumber, more brave. I don't know. Maybe they drink more alcohol, and it's like when you hear, "Hey, watch this," the next thing usually is probably going to be some type of injury. But it's an older age, 43. But there's a high incidence though of teenagers and younger males, especially. But then I think what you're finding is there's like 16 to 30 years of age, large number of injuries. Then I think what you're finding then on the older end, it's kind of like a skew where that older age now is they're pulling this number up. So you're seeing 43 being the average, where it's usually a lot more of the patients actually being injured and suffering spinal cord injury, 16 to 30 years of age, and the older males that are falling and ending up with these spinal cord injuries from falling, you're seeing that that older age is skewing this number up this way. And that's why you're getting that 43. And it makes sense because, the life expectancy has increased from the 70s too. So therefore, you're pulling that average age up. Males, 78% spinal cord injury occurs in males. Interesting. And the reason why is a lot of this is attributed to high risk activity, high risk behavior, and also sports injury. 50% of the spinal cord injuries are considered to be complete, and 50% are considered to be incomplete. What we're really going to focus on tonight is going to be the incomplete spinal cord injury. I'm going to talk a little bit about the complete. The completes are easy. It's the incompletes that become a little bit more confusing and so forth. We have to have a little bit more diagnostic ability to say, yes, this is. So what's important is, again, I want to teach you to rule in. To rule out is actually, easy to do, but to rule in and say, yes, I think this patient has a potential spinal cord injury or vertebral injury. So, evaluative criteria. When I started in EMS back in 1979, the big thing was mechanism of injury. Everything was mechanism of injury, everything. We called helicopters based on mechanism of injury. We'd fly helicopters into scenes and the patient was standing next to the, ambulance smoking a cigarette. And they're like, well, where's the patient? Here he is right here. He doesn't want to go with you guys. Or can he finish his cigarette before he gets on the helicopter and gets charged? I don't know, Justin, what is it? 15 grand, 20 grand, whatever it is now. I don't know what it is. And we were calling.
That's on the cheap side.
That's on the cheap side. Oh, geez. Mechanism of injury. You're like, wow, this is kind of crazy. It's funny. I don't know. How many of you remember Mike Dunham, Dr. Dunham? He was the trauma surgeon at Mercy. I know a lot of people didn't like Mike Dunham because he had like this bedside manner that was like horrendous. But I tell you one thing, that guy was brilliant. I actually served on a research committee with him, a trauma research committee. And the guy was just brilliant and was so logical. And I loved learning from him, and he loved to teach. And he treated me as a paramedic. He treated me actually, he was not condescending at all. His residents, oh my God. I mean, geez, they'd pee their pants when he would walk by. I mean, but I learned so much from him. And years ago, Mike Dunham would say to me, I've talked about mechanism of injury, and he would say, I don't care. He had that Tennessee drawl. I don't care about mechanism of injury. I'm like, what are you talking about, Mike? So you don't care if this patient jumped out of a 3-story window versus a 3-foot window? Nope. You don't care if this guy was involved in a motor vehicle crash going 80 miles an hour versus 10 miles an hour? Nope. What do you mean, Mike? I said they did research. ASAP published research that showed that much more aggressive care was done. They did this years ago. They did this in the 80s when we had Polaroid cameras. And what they did, they actually did this in Toledo, Ohio. What they did was they actually had one person on the crew that would walk around an accident scene and take pictures of the mechanism of injury, the vehicle, the impact of the vehicle, where it's at, intrusion in the door, the front compartment, windshield, things like that. And when they got to the emergency department, they would show the physician, and they showed, and it was a published article in ASAP, and they showed that the care was so much more aggressive. And I said, you don't care about that, Mike? Nope. I said, what do you care about, Mike? What the patient presents like? And I was like, well, this guy's a jackass. Seriously, come on. Mechanism of injury is so important. We base everything on mechanism until one morning, it's about 3 a.m. I'm laying in bed going, you know what? The guy's absolutely right. Absolutely correct. Mechanism of injury really doesn't tell us anything other than be suspicious. It doesn't tell us about what's injured, how bad it's injured, what organ system's injured. All it tells us is be suspicious that maybe these organs are injured, these limbs are injured, these bones are injured, or whatever it would be. So what we've gone to now is basically relying on physical assessment. Mechanism of injury is meaningless. It truly is meaningless other than heightening your suspicion. Physical assessment is the key. What is your patient presenting with? What physical signs and symptoms are they presenting with? What diagnostic information are you gathering from them? That's going to tell you about injuries and about criticality of those injuries, not mechanism of injury. Mechanism of injury is very, very limited in the information it provides to you. Matter of fact, the 2011 guidelines for field triage, I don't think this came out again. I know that they are revising it. This was the latest adoption of the guidelines for field triage of the injured patient. If anybody knows that it has been released, speak up, let us know. But this was published by the American College of Surgeons Committee on Trauma, and they got no traction with it. They did this in like 2009, and they got no traction. So they went to the CDC and said, we need to get this out to everybody. And that's why the CDC helped them out, and they re-released it in 2011. But what I want to point out, and it's still valid today, but what I really want to point out to you is, look, the number one criteria for taking a patient to a trauma center, and again, it's going to be the highest level of trauma center that you can go to in your destination protocols. It's based on these vital signs and level of consciousness, not mechanism of injury. It's based on their Glasgow Coma score. It's based on their diastolic blood pressure and their respiratory rate. Now, if these all fall within the normal limit, then the next thing you do is you focus on the anatomy of the injury. What type of injury does this patient actually have? It doesn't matter the mechanism. It doesn't matter how they got it, but it's focusing on anatomic injury. So if you have any of these criteria under box 1 or box 2, you should transport this patient to the highest level trauma center, preferably a level 1. But if you don't have a level 1, you're going to go to level 2, whatever, someplace that could deliver trauma care. And if they don't have anything in 1 and they don't have anything in 2, then you look at mechanism of injury. You say, okay, did any of this stuff happen? And if it did, then they say, well, you probably should go to some place that might be able to do some kind of trauma care. Might be a level 4, might be a level 3, but they don't need a level 1 or level 2 trauma center, and they definitely don't need a helicopter. So all I want to point out is that mechanism of injury went down to number 3, and it's not even like a, oh yeah, definitely go to a level 1 or level 2 trauma center. It's not. What you're really focusing on is their level of consciousness, their vital signs, and anatomic injury. Then you have the special considerations too, like older adults, children, people on, anticoagulants, burns, pregnant patients and things of that nature. So just want to point that out, that mechanism of injury has really taken a back seat. And you're not going to go to a scene and say, when you roll up, you're not going to go, oh, we're going to mobilize this patient. Well, we're not going to mobilize anymore because we're going to SMR this patient because of the mechanism of injury. Nah, not true anymore. You're not going to do that anymore. You're going to assess the patient, and the patient's clinical findings are going to determine whether you're going to SMR the patient or not. So how many of you have gone to a scene where you rolled up to the scene and you look at your partner and you say, this one's going to be dead? And then you're like, where's the patient? I remember John Booth and I one time had a crash. I think it was off of Jacobs Road in some remote area. It was a guy driving a Corvette with the old T-tops. And this guy was like 3 o'clock in the morning. And the Corvette was on its roof. The T-tops were torn away. And this Corvette had skidded out into the middle of like this cornfield. And we rolled up, and this Corvette was all banged up. And we rolled up to the scene. The tow truck was already there, like in a lot of cases. And John Booth and I are out there searching frantically. Driver's not in the vehicle. We're searching the cornfield. We're searching everything. Can't find anything. Again, it's pitch black. It's 3 o'clock in the morning. Go back to the tow truck with the driver. There's 2 guys, both standing there smoking cigarettes. We went back and we said, do you know anything about this crash? Do you know if anybody saw anybody get out or anything, or who was driving? And the guy smoking his cigarette goes, oh, I was driving. Like, are you kidding me? Oh, yeah. He had 0 injuries, none. Physically, physiologically, completely fine. But yet we rolled up saying, yeah, boy, that's a severe mechanism of injury. I'm sure you all have had those calls where you've rolled up and you said, man, this is going to be a bad one. This is going to be a bad one. And then you're paranoid. You're like, well, I'm missing something because this patient is not presenting like they're in any trouble whatsoever. They don't have any critical injuries. I don't know. I mean, there should be something. And that's okay. It's okay to be paranoid. It's okay to keep thinking like there should be more injury than what we have. How about this one? Have you ever rolled up to a minor accident scene and you roll up and you're like, yeah, this is going to be nothing. We're probably not even going to transport. Then you end up transporting a patient on the red, calling for a trauma team. I'll tell you a little story. It was Corinne Fullerman that she's actually Corinne's a CRNA now. She doesn't live in Ohio. I forget where she's at. But Corinne was riding as a student. And we had our radio system for you guys who went through the YSU program. Remember that damn radio. And remember the KNDD 969. And so she had the radio and they got toned out for a motor vehicle crash. And so she reported in. I was on the radio that day and I said, okay, well, contact me when you arrive on the scene. And so she got on the scene and she contacted me. And this was right on the corner of number 3 Boardman House there, Lockwood and Shields. And she contacted me when they got there and she said, oh, this is a very minor accident. We're probably going to be clearing the scene soon. I said, okay. Then I don't hear from her. And next thing I hear from her is like, I could hear the franticness in her voice and I hear sirens in the background. And she says, we're en route to St. E's. We called for a trauma team. I'll contact you later. I'm like, okay. And I just said, when you get to the hospital and you have a minute, just call me on the landline. Because now I'm like, what the heck is going on? She said it was a minor injury. When they rolled up to the scene, they had 2 cars that crashed in the intersection. Very minor accident. It was a rainy day. One car was trying to turn as the other car was coming through, but it was almost like a front end collision. And was before airbags. And so the driver of the one vehicle was out, the driver of the other vehicle was out, and there was another young girl. She was 21. She was in the passenger side of the vehicle, and she was still inside the vehicle. And they just thought that this girl was still sitting inside the vehicle because it was a light rain outside. And so the driver of both vehicles, they were perfectly fine. There was very minor damage to both front ends of the vehicles. They were still drivable. And then somebody, one of the medics on the scene said to Corinne, why don't you go in and just make sure that girl's okay? Goes in. This girl is extremely pale, has a severely decreased mental status, pale, cool, clammy, tachycardic, classic signs of frank hypovolemic shock. Calls the other medic over. They come over. They look at her. They're like, what the heck? There's no impact marks. Nothing. Windshield's intact. Everything is intact. No impact marks, nothing. They rapid roll her out. They get her in the back of the ambulance. They strip her down completely. They cannot find anything on this girl. 21 years old, healthy young girl. She had a very minor, not even a contusion. It was like almost like a brush burn to her right upper quadrant, right underneath her right costochondral margin. They run her in. She is crashing bad. Run her in. They call a trauma team. They trauma team her. They take her up to surgery, and she died in surgery. And she died in surgery. They found out later from a lacerated liver. And it was like they were just perplexed because they're like, we didn't think anybody was injured in this accident. Well, here's what happened. They found out from the coroner's investigator. What they found out was this girl, when she put her seatbelt on, she didn't like how the belt came across her neck, so she tucked it underneath her arm. And when they got in that crash, when they hit, it was like almost like a head-on collision. She went forward and the belt locked and it rolled underneath her right costochondral margin. And it was enough blunt force that it actually tore her liver right in half. And she ended up dying. And there again is a mechanism of injury that was exceptionally minor. I mean, it was probably about a 10-mile-an-hour collision that they were involved in. So, and the point of the story is this, is like mechanism of injury tells you nothing, because you could have severe mechanism of injury, very minor injury. You could have minor mechanism of injury with severe injury. I can tell you this, before they actually came out with lap belts, or with shoulder belts, and they only had lap belts, we used to deal with a lot of minor mechanisms of injury with major head injuries, because that lap belt was a pivot point where the patient would come forward and smack their head on the windshield. And so we'd have minor accidents with a lot of head injury. So mechanism of injury doesn't really tell you anything. So what's the most important thing in determining a potential spinal injury? When I'm saying spinal injury, I'm talking about cord and vertebral column. The vertebral column is the bony column. The cord is the neuro tissue. It's assessment. I can't emphasize that enough. It's assess, assess, assess. And again, when you get done with this lecture, you're going to feel exceptionally comfortable in your assessment. So if your assessment findings are positive, does that mean you have to do complete spinal mobilization? No. I mean, look at this. They're probably proud, like, oh, look, we got this guy completely immobilized. Look at him. Look at his head. Look at his cervical region. Look at the sag in his thoracic spine. His lumbar spine comes back up again. Then his legs are dragging down. This guy, look at his eyes. It looks like he smoked some dope before they did this. But it's like, this is the worst immobilization ever. They probably got A's because it looks so awesome. It's terrible. This immobilization idea is terrible. So no, we're not going to do this kind of crazy nonsense anymore. But what we're going to do is we're going to do spine motion restriction. We're going to restrict the spine from unnecessary movement. The head, the neck, the cervical spine, thoracic spine, the lumbar spine, and so forth. We're going to restrict it from unnecessary movement. So you look at this and you say, all right, so, man, I don't know. I don't want an anatomy lesson, but I'm telling you what, there's some very simple things that I want you to learn, okay? One thing I want to point out here is look at where the spinal cord actually ends at about L1 to L2. That's where the spinal cord ends. But if you notice this group of nerves, okay, you have what's called here the cona medullaris, and it's kind of like the point where all these nerves now start coming out. And these are all these sacral nerves. And these nerves are called the cauda equina. Equina, it refers to, it means horse's tail, because that's what it looks like. So you can have injuries to these nerves in here where you're going to find injury indications into like your sacral nerves and things like that. And we're going to talk about it. But just keep in mind that the spinal cord itself ends at about L1 or L2, okay? And one thing I want to point out, the most important thing is that the spinal cord, the actual cord, not the bony vertebrae, but the cord is an extension of the brainstem. What does that mean? The spinal cord acts like brain tissue, just like it. The same stuff that could damage brain tissue will damage the spinal cord. When your patient becomes hypoglycemic, not only will it damage the brain, it will also damage spinal cord tissue too. So keep that in mind. Anything, hypoxia, hypercarbia, whatever it might be, could damage the spinal cord cells just like it will damage the brain. So just keep that in mind. We'll talk about that a little bit too. Okay, so just briefly, here's what I want to tell you. So what you have is you have spinal nerves, okay, that enter in and exit out of the spinal cord. Your nerves that actually are going to the spinal cord with sensory information are called afferent nerves. They're sensory nerves. They're afferent nerves, and they take sensory information from the periphery and they transmit it to the spinal cord, and then goes into the right nerve tract, whether it's light touch, pain, position, whatever it might be, and it goes up. Sensory nerves take the impulse to the spinal cord, and the spinal cord transmits that impulse up to the brain to be interpreted by the brain. Now, exiting out of the spinal cord is a motor nerve, which is called an efferent nerve. And that nerve actually now is transmitting an impulse. It's a motor nerve. So it's transmitting an impulse back out to a muscle to cause the muscle to move. So it's taking an impulse from the brain down the spinal cord in a spinal tract, out the spinal cord, and now sending that sensory or that stimulus to a muscle and causing the muscle to move. Motor means movement. Motor impulses come from the brain, down the spinal cord, out the spinal cord, causes a muscle to move. Sensory, the afferent tracts, take an impulse, take it to the spinal cord, take it up to the brain for the brain to actually interpret that impulse. Here's what I'm going to tell you something important. If you want to assess the patient's brain, if you want to assess the patient's brain function, if you want to assess the patient's integrity of their brain, you can only apply painful stimulus to the core of the body. You cannot test the integrity of the brain by testing the periphery. You can't pinch the nail bed, you can't pinch the foot, you can't stick them with an angiocath or whatever. When you are testing the integrity of the brain and you want to determine whether the brain has function or not, meaning if I do a trapezius pinch and that patient responds with a moan or they try to grab my arm, that's testing the integrity of the brain. Because what I'm trying to do is say, if I apply a painful stimulus to the body, like a sternal rub, and they reach up and they go to grab my hand, or they make an attempt to grab my hand, or they moan, or they groan, I know one thing, that impulse was taken by a sensory nerve, an afferent nerve, to the spinal cord, up the spinal cord. The brain interpreted that sensory stimulation, and it sent down a correct impulse. It caused them to reach for your hand. It's like at the trapezius pinch, they say, if the hand comes up past the ear, it's a very specific, sensitive test saying they got good brain function, okay? If I did a sternal rub or if I did a trapezius pinch and the patient does nothing, then I have to wonder if that brain is still intact enough because it's not even sending out a response. But if I pinch and that patient now grabs my hand or makes some motion, okay, like they're going to grab my hand, like flexion, okay, then I think, wow, well, or they try to withdraw from the pain. That's great, because if they're trying to withdraw from the pain, I know one thing, the brain's getting the impulse, the brain interprets the impulse, and it sends out a correct response. And if it's sending out a correct response, it's got to have a good integrity. It's still got to be functioning at a pretty high level to send an impulse down saying, get away from the pain, okay? Here's the problem. Here's the problem. If you assess brain integrity by assessing peripheral painful stimuli, nail bed pinch, web pinch, stick them with a sharp object, whatever it would be, pinch them hard, hands, arms, legs, feet, anything to the periphery. Here's the problem. When you pinch their hand, that impulse goes in through an afferent nerve. That afferent nerve takes that impulse into this part of the cord. This is called an interneuron. And what we have in the cord are referred to as reflex arcs. And if that impulse gets into a reflex arc, that impulse goes right from this afferent nerve into a reflex arc and right back out that motor nerve, that efferent nerve. And what's the response? The patient withdraws from the pain. I could have a patient that is virtually brain dead, but if I trigger a reflex arc and pinch their hand, they could withdraw from the pain. Now, me personally, I'm going to go, well, this is a great sign because I pinched them and they withdrew their hand. That's a reflex arc, okay? So that's why you can't use peripheral painful stimuli to check the integrity of the brain. You will only use peripheral painful stimuli to check the integrity of the spinal cord, okay? When you're checking brain integrity, you could do supraorbital pressure, you could do trapezius pinch is actually one of the best ones you can do. You could do sternal rub, but sometimes it takes 30 seconds. Nipple pinch is in the medical literature. I'm not making it up. A testicular twist is in the medical literature too. I mean, I can see, you females going to work pissed at your husband or boyfriend, and can't wait to do a testicular twist to see if this guy's going to respond or not. But it has to be to the core of the body, okay? Peripherally, you're going to use it to test the spinal cord. All right. So now, here's what I want you to learn. There are only 3 things I want you to learn about this, okay? Well, 3 things I'm going to teach you about the spinal cord itself, okay? Notice where the big yellow arrows are right here. These big yellow arrows, they're pointing to these tracks right here. And these tracks are called cortical spinal tracts. I can care less if you ever remember the name cortical spinal tract. But what I do want you to remember is they are motor tracks. And motor means movement, okay? And when you expect movement to occur, that means that the impulse is doing what? Coming from the brain, down the spinal cord, out the spinal cord through spinal nerves, and causing muscles to contract. You're causing movement, okay? So, in the lateral portions of the cord, look, lateral portions of the cord, and keep in mind, this here, this right here, is the anterior portion of the cord. Notice anterior, posterior, left, and right. This is the posterior portion, the fasciculus cuneatus, fasciculus gracilis. These are the posterior portions of the cord. This is anterior. So this is left lateral. This is right lateral, because this is a cross section of a patient standing looking at me, okay? The motor tracts are located in the lateral portions of the cord, okay? So here's what I need you to know about these tracts, okay? Here's what I need you to know. The motor tracts are carried down the sides of the cord, and the impulses are going from the brain, down the cord, out to the peripheral nerves, causing movement. So if I want to test that track, I have my patient move, okay? As simple as that. Now, here's one thing that's real important. The cortical spinal tract on the left, okay, carries impulses that makes the patient move on the left. So the movement occurs on the same side of that cortical spinal tract. So that means if I want to test my left cortical spinal tract, my left motor tract, I have the patient move on the left. If I want to test my right tract, motor tract, cortical spinal tract, I have the patient move on the right. Now, depending on what level of the cord, if I want to test higher, I'll do upper extremities. If I want to test lower, I'll do lower extremities. Okay? Motor goes from brain down the cord, out, causes movement. The movement occurs on the same side of the tract. I want to test the left cortical spinal tract, I make a move on the left. I want to test the right cortical spinal tract, I make a move on the right. We got it? Any questions? You guys okay? This actually, it's actually easy, but it makes so much sense clinically in a clinical application. Okay, the next set of tracts are called the spinal thalamic tracts. I don't care if you ever remember the name spinal thalamic. I want you to remember that they're sensory tracts, but more specifically, they pick up the sensation of pain. Now, they also pick up other things, temperature and so forth, but I just want you to focus on pain. So that means if the patient is experiencing pain, it is the spinal thalamic tracts that are located in the front of the spinal cord. So it means the front of the spinal cord is transmitting the sensation of pain up to the brain. We know the sides of the spinal cord are transmitting impulses from the brain down, out, and causing muscles to move. So the spinal thalamic tracts are the pain sensory tracts, and they're located in the front of the spinal cord. Here's one thing I need you to remember, though. So these are sensory tracts that are coming down, okay? These sensory tracts are coming down. Or I'm sorry, not coming down. They're going up. These sensory tracts are going up. They're taking information up to the brain, and the information that we use that they're taking up to the brain is pain. I'm applying pain to the body. We're testing the spinal cord, so I'm applying pain to the periphery, not the core of the body. I'm applying pain to the periphery. And that pain is being transported by these pain sensory tracts, spinal thalamic tracts, up to the brain. Okay, so here's something that's unique about these. The spinal thalamic tract on the left, when that sensory impulse enters into the cord, just right above that spinal nerve, it crosses over to the opposite side. So that means that if the patient, I'm applying pain to the left hand, that sensory impulse, that pain impulse is being transported up the cord on the right-hand side. It's opposite. If I apply pain to the right hand, it enters into the cord, it crosses over, and that impulse is transmitted up the left side of the cord. Okay, so if I want to test the anterior portion of my cord, and I want to determine that these pain tracts, these spinal thalamic tracts, what did I do? Did I go forward? These spinal thalamic tracts are still intact, then what do? These tracts here, sorry, I was on the wrong side there, is it? These tracts here are the spinal thalamic tracts. If I want to test, somebody tell me, if I want to test my left spinal thalamic tract, my left, where do I apply pain?
Right side.
Right side. Beautiful. And if I want to test the left spinal, or the right spinal thalamic tract, where do I apply pain?
Left side.
Left side. Perfect. Makes sense? Opposite of motor. Motor, if I want to test the motor track on the right, I make a move on the right. If I want to test the motor track on the left, I make a move on the left. However, if I want to check the anterior portion of the cord and I want to check the right spinal thalamic tract, I have to pinch them on the left. If I want to check the left spinal thalamic tract, I have to pinch them on the right. And again, we're talking about periphery. All right, you guys got it. All right. The next then are your posterior columns. They're called posterior columns because they're located in the back of the spinal cord. Remember, this is the front of the patient, this is the back of the patient. I could care less if you ever remembered fasciculus cuneatus, fasciculus gracilis, just know them as the posterior columns. Now, these carry sensations too, but it's more light, it's light touch is what we're going to focus on. But it's like proprioception, it's a lot of it has to do with light, it's not temperature, it's proprioception, it's vibration, it's things of that nature that these are carrying. But what we're going to focus on is light touch. Notice they're in the back of the spinal cord. Now, because they're sensory, that means the impulse is going to come in and it's going to go up to the brain. Okay? So the way that we test this column is we apply light touch, meaning, okay, ma'am, I want you to close your eyes. Tell me, what hand am I touching? And I'm basically just touching it lightly. Oh, that's my left hand. Okay. Now, the posterior columns, like the motor columns, the light touch impulse is carried up the same side that you're assessing. If I do light touch on the left, that light touch impulse is carried up the left side of the cord. If I light touch on the right, that impulse is carried up this posterior column on the right side of the cord. They're same side. The only one that's different is the pain. The pain is carried on the opposite side of the cord that you apply actually the stimulus. Now, how many of you said before, now if my patient, whoa, what the heck was that? There's some echo in there. How many of you said before that if my patient could feel light touch, well, they can surely feel pain, and I'm not going to pinch them, because if I pinch them, I'm just making them uncomfortable. How many of you at this point are going to say, well, I'm never going to assume that again? Because I know what? My light touch is carried way back here, and my pain is carried up here. Could I have a patient who has an injury only to the anterior portion of the cord, and you only touch them, and you make them move, and you only do light touch, and you make them move, and you only do light touch, and you never do pain? Could you walk away with this patient and never ever realize that they have a spinal cord injury? Absolutely. Absolutely. You got to get away from the practice of saying, well, if they could feel me touching, they could obviously feel pain, because now knowing the anatomy, they're two totally separate columns that actually transmit those impulses. Okay? All right. Just say this: sensational light touch is carried by multiple independent tracts, some posterior, some anterior. So it gives you a little bit of different information sometimes, but for the most part, I'll tell you the typical syndromes and so forth, but just do keep that in mind. Okay. So I could never remember this. You know, you always wonder, like, how in the hell am I going to remember this? I couldn't remember which one is crossed over, which one. So I made up this mnemonic, LMNOP. If I'm testing the right side of the spinal cord, I know that I'm going to test motor on the right, light touch on the right, but no pain. Pain, I got to go to the left to test my right side of my spinal cord. Okay. All right. Does that make sense? All right. So if I'm going to do LMNOP, when I want to test right side of my spinal cord, motor is same side, light touch is same side, but not pain, I got to go to the left side to test the right side of my cord. Okay? LMNOP, motor, light touch, not pain. Pain, you test on the opposite side. Make sense? All right. Myotomes are basically, at what level of the cord are you going to clinically see movement in your patient? And these are important. Now, one thing I want to point out, the phrenic nerve exits out at the cervical level 3, between 3 and 5. And that's why I always say, if you have a spinal injury or vertebral injury between C3 and 5, it's very dangerous, because if you actually encroach on the phrenic nerve innervates the diaphragm, and you can lose the diaphragm. The diaphragm is the effort in breathing. About 60 to 75% of the effort to breathe comes from the diaphragm. So if you knock out the diaphragm, you're going to have a patient who is hypoventilating, because they can't generate a great enough tidal volume because they don't have the diaphragm. So keep that in mind. What I do want to point out is C6 and C7, flexion at the elbow. So that means if I go like this, okay, can you guys see me? I don't see my, am I on, can you guys see me on camera? You guys awake?
At the bottom, we can see you.
Oh, you can. Okay, so you can see me doing this?
Yeah.
Okay, my hands. All right, so if I have the patient go like this, okay, what I just did was I checked their motor tracts at the level of the 6th cervical vertebrae. And if I have them go like this, I just tested the level of the motor tracts at the level of C7. So realistically, if I wanted to check the right motor track at C6, I would have them go like this. And if I wanted to check the right motor track at C7, I'd have them go like this. But when I have them go like this and like this, I just checked right motor track, left motor track, C6 and C7. And then flexion of fingers. I mean, there's another one that I'll tell you. Flexion of fingers or abduction of fingers. If you have them go, remember, was that Spirit Fingers or whatever, that movie? But abduction of fingers, that also will test T1. You have them go like this, both hands. And if they go like this, I test in my right motor track, T1, left motor track, T1. Okay. And there's another one I'm going to teach you, that's C7 too. You guys have been doing this for a long time. All right, I'm going to put my hands on the top of your feet. Okay, I want you to pull your feet up towards your head. Okay. What you're actually doing is you're checking those nerves at the level of L5. Okay. Remember, the spinal cord ends at between L1 and L2, but now you're checking that cauda equina. You're checking that group of nerves traveling through at the level of L5. And then what you do is you put your hands on the bottom of the patient's feet and you say, push down. And when they're doing plantar flexion, you're saying push down like you're pushing on a gas pedal. That's checking actually that cauda equina at the level of sacral 1, sacral 2. Sacral 5 is the lowest. Believe it or not, sacral, the lowest, the best way to check the lowest level of the cauda equina is rectal sphincter tone. I don't recommend that you do that. You probably will be talking to Matt, and you probably might be going to jail. So be careful. Don't be, gloving up and, testing the, the S4, S2, S3, S4, S5. Dermatomes, dermatomes are sensory. Okay. The myotomes are muscle. That's movement. Dermatomes are sensory. And the one that, it's like, these are crazy too. You can see how different they are, how these tracks vary and so forth. The only thing I usually say is just remember, like, T4 is the nipple line, T10 is the umbilicus, S2, S4 is the perianal region, C4 is the, suprasternal notch. The most thing that, the most important thing to remember is where you're getting a dysfunction when you're checking for sensory. Okay, I'm not going to get real crazy and saying, well, you got to check here and here and here. What you're going to basically do is check light touch and pain in 4 extremities and move your way up if they're not feeling the pain. Okay. All right. We've been talking about spinal cord. Keep in mind that a vertebral injury is a bone or ligament injury. Okay. It's a bone or a ligament injury. It doesn't mean that because the bone is fractured or a ligament pulls the bone out of place, or you have a sprain or something of nature, that the spinal cord is injured. So here, let me clarify this. The spinal cord is nervous tissue, just like the brain. The spinal cord is responsible for neurofunction. And when I say neurofunction, I mean motor function and sensory function, light touch and pain. If you want to check the spinal cord, you have to check motor function, light touch, and pain. Okay. If you want to check the vertebral column, you would check it like you would check for any other bone or ligament injury. And that is for tenderness, on palpation, that is for pain, that is for any anomaly, like you might find that there's an anomaly when you're palpating, that it feels like it's bulging or something of that nature. Just because there's a vertebral injury doesn't mean that there's a spinal cord injury. Just because there's a spinal cord injury doesn't mean there's a vertebral injury, okay? A lot of times those occur independently. 63% of cases of spinal cord damage have no vertebral column injury, and that's real important because there's one major thing that's missing in your clinical assessment. Remember, the vertebrae is assessed with tenderness, pain, and palpation. The spinal cord is assessed by doing a neurologic assessment, pain, light touch, motor. Okay. All right. We want to take a quick break. Matt, Larry?
What was that, Joe?
This is a good point to take a quick break.
Yeah, that sounds good. How about a 5-minute break? We'll see you back here around 7:05.
Yeah, 5 minutes would be awesome. Thank you.
Okay, everybody put their hands up, please, for so we can take attendance. All right, is everybody back? Joe, you ready to go?
Yes. Is my slide still up, Matt?
Sure is.
Okay, good.
All right,
Okay.
folks, let's get started again.
Sorry for the short break, but I do want to finish on time. So yeah, we have been getting out a little bit late on all of these, but I know the information's been great, though. I know I've loved every one of these. So, all right. So spinal cord injury. Now we're talking about cord. We're not talking about vertebrae. We're talking about cord. There's a primary and a secondary injury that you have to be concerned with when you're talking about spinal cord injury. The primary injury is what occurs from whatever that mechanism is. If a patient gets shot and that bullet enters and damages the spinal cord, that's the primary injury. If somebody gets stabbed and that knife goes in and damages the spinal cord, that's the primary injury. If a bone fractures and it lacerates a portion of the spinal cord, that's a primary injury. There is nothing that we're going to do that's going to prevent or turn around or reverse that primary injury. That primary injury is done. There's nothing that we can do. The only thing I'll tell you that we can do is through spine motion restriction is prevent us from further aggravating that injury, especially if it involves any type of bony fragments or anything of that nature. But there's nothing we're going to do. The injury is done. The injury to the cord is done, and we're not going to do anything to reverse that. However, a secondary injury, again, I said earlier, this is just like a brain injury. Same exact thing. If you have a patient that suffers some type of blunt trauma to the brain or penetrating trauma to the brain, this is the exact same pathophysiology that you're going to find to the spinal cord. So edema is going to occur. Edema is going to occur as a result of injury, where there might be actually vessel damage and leakage and capillary permeability and so forth, where edema is building up. There is a lot of times there's an inflammatory response that occurs to injury, and this inflammatory response, that's the same type of inflammatory response that you get from like a bee sting, except this is localized to the spinal cord in that particular area of injury. So what you get is you get further edema, because now not only do you have potentially blood leaking out or you have damaged vessels in that specific area, but now you have the release of chemical mediators that are causing capillaries to become very permeable. And when these capillaries become permeable, they're leaking out plasma volume into the interstitial space, causing more edema, causing more pressure on that tissue. And then you're getting vasodilation to occur in that area too. And that vasodilation is filling that vessel and taking up more space, causing more pressure. So now we got this pressure building within that tissue. When you have pressure building, you get compression, and compression of other nerves, compression of neural tissue, compression of vessels. When you compress nerve tissue, it doesn't work well. When you compress vessels going to nerve tissue and reduce the blood flow, it doesn't work well. We know that because of stroke and head injury. We got ischemia. We have to make sure that we are preventing ischemia, keeping our patient's airway open, keeping our patient ventilated if they need to be ventilated, oxygenated, well oxygenated, and so forth. Again, you have to be careful that any movement of the patient, you're not going to cause any vertebral column fragments that are sharp fragments to move and injure that spinal cord further. We have to prevent against hypoxia. We have to prevent against hypotension. Okay, who can tell me? Who can tell me? Somebody tell me. You never ever let your brain injured patient systolic blood pressure fall below what? Somebody tell me. You have a brain injured patient. You will never let their systolic blood pressure fall below
90.
what? 90. Correct. Absolutely. Thank you. It is exactly the same for the spinal cord injured patient. If you have a spinal cord injured patient, or you suspect the spinal cord injured patient just like the brain, you will not allow their systolic blood pressure to fall below 90. You're going to use fluid for the most part. And again, if this is a neurogenic component, we'll talk about that. You may use pressors, but at the same time, keep that blood pressure in mind, because this means if you got somebody who's stabbed in the chest and they also have a brain injury or they have a spinal cord injury, and you are getting all the indications of a spinal cord injury, and they have a stab wound to the chest, you're thinking, well, I want to do permissive hypotensive because of the chest injury. You can't. The spinal cord tissue and the brain tissue takes precedence, and you have to maintain the systolic blood pressure of 90. And I'll explain that to you in a little bit. Do not allow them to become hyperthermic, hyper, not hypothermic, hyper. Do not allow them to become hypoglycemic. Remember the first lecture. If they become hypoglycemic and they don't have the glucose getting into this neural tissue, they can't do what? They can't make ATP. And if they can't make ATP, what shuts down? Sodium potassium pump. And if the sodium potassium pump shuts down, what happens to that sodium? Comes into the cell. I think it was Larry who said for every sodium that comes in, it draws in 3 waters. That cell begins to swell, collects water, eventually it ruptures. Do not allow this patient to become hypoglycemic. At the same time, do not give them glucose if they don't need it. Do not ever give your brain injured patient or spinal cord injured patient glucose if they don't need it. Most of the places are using a B-gel of 70 milligrams per deciliter. If their blood glucose level is below 70 milligrams per deciliter, then that is an indication that with signs and symptoms, that is an indication that you would go ahead and give glucose. But don't overshoot. Do not overshoot. You don't want this patient to have an excessive amount of glucose. Why? Because we know what? Glucose crosses the blood-brain barrier and this nervous tissue. It doesn't need insulin. So the glucose is going to freely cross. Glucose is a big molecule. Not only does charged particles like sodium and so forth attract water, big particles attract water. Glucose is a big particle, and it gets right across this neural tissue. That means if all this glucose is getting across the neural tissue, what's it bringing with it? Water. What are you doing? Worsening the edema. So you don't want to give them glucose if they don't need it. Okay, so a complete spinal cord injury is where the spinal cord is completely injured all the way through. Nothing is spared. It is completely injured all the way through. And typically what you're going to find is quadriplegia, also known as tetraplegia. Tetraplegia seems to be the new term. It's the same thing. And paraplegia. Quadriplegia from the neck down, paraplegia typically from the waist down. They lose all motor sensory function at that point. That's a complete spinal cord injury. That cord is completely injured all the way through. An actual physical transection is rare, where you actually take the spinal cord and you actually complete the transection. It's like in 2 parts. That's really rare. But it's usually a physiologic transection where the injury has occurred, the swelling has occurred, and the cord is deadened in that area. That means no impulse can get up, no impulse can get down. That's a complete spinal cord injury. Okay? Complete flaccid paralysis immediately following impact does not always indicate permanent neurologic dysfunction. You all learned about spinal shock, and everybody thinks, well, spinal shock is this neurogenic component. Well, spinal shock might have a neurogenic or vasogenic component, but what spinal shock really means is that your neurons in the spinal cord may actually shut down, and it's usually for a period of about 24 hours. That's why a lot of times they say, we'll know in 24 hours the extent of this injury. Because what happens is this: when they have the edema, when they have the inflammatory response, there's a reduction in perfusion of blood flow to those neurons. And if you recall in the stroke lecture that Larry did, that I couldn't do because I couldn't talk, remember that, 40 to 60 milligrams, 40 to 60 mLs per gram per brain per minute, and then once it fell below 18, the cells became electrically silent, which means that they are still alive. Their neurons are still intact, the cell membrane, but they don't have enough energy to actually work, okay? And the best analogy of this is if you have a laptop, okay? If I have a laptop, I have a laptop right here. If I open it up, when I open my laptop begins to function, okay? It turns on, okay? Because what I did when I opened it up is I restored the electricity to my laptop. But if I close it, what happens? It shuts down. It doesn't mean that it's useless. I'm not going to throw it away, because as soon as I open it back up and I restore that energy, all of a sudden it turns on and I can use it. This is what electrically silent is. When the perfusion drops to a point where it's really low, those cells become electrically silent, meaning they don't have enough ATP to cause them to work normally. That means you're not going to get a motor response. You're not going to get a pain response. You're not going to get a light touch response. But it doesn't mean the cells are dead. Because as soon as you can restore that perfusion, restore the O2, restore the glucose, and get that ATP going again, the cell turns back on again, as long as that neural membrane has not been damaged, okay? So it goes from electrically silent to back on. That's why they wait, okay? That's why you've seen stroke patients. You take them into the hospital, you know, and that ischemic penumbra that Larry had talked about. You take them in the hospital like, oh my God, this poor person has complete left-sided paralysis. And then you go back to visit them the next day and they're sitting there eating with their left hand. You're like, what the hell happened here? They had complete left-sided paralysis. Well, they didn't. Their brain cells were electrically silent, but as soon as they restored perfusion to that ischemic area, they all turned back on again because they weren't dead. Same thing happens with the spinal cord. That's why they wait 24 hours. So even if you see a patient in the field who has complete loss of motor and sensory function, it doesn't mean that that's permanent, okay? They have to wait 24 hours because those cells might just not have enough perfusion because of the edema, because of the inflammatory response, the poor perfusion, okay? Now, there might be a neurogenic or vasogenic component to spinal shock. That's spinal shock. The neurogenic or vasogenic component is what you learn is where they become hypotensive, they're bradycardic, their skin's warm, red, and flush below the lesion. They have vasoconstriction where their skin is pale, cool, and clammy above the lesion because the sympathetic nervous system can still function and so forth. That's the neurogenic component. Well, the neurogenic component, if it does occur in spinal shock, it's a relative hypotension. Typically, the systolic blood pressures don't drop more than to around 80. Usually they hover around 80. But again, remember, we got to keep that systolic above 90 to keep the perfused. And the bradycardia is relative. Remember, your SA node has an intrinsic ability to fire between 60 and 100. So it's going to intrinsically fire. It's not going to fire less than 60. And so typically the heart rate's going to be around 60, maybe 70. And again, vasodilation occurs below the lesion because those vessels are no longer getting that sympathetic stimulation and maintaining tone, so they dilate. So the warm red blood goes out to the periphery, but above the lesion, they're still getting sympathetic tone, and you're going to see pale, cool, clammy skin. That's the neurogenic component, okay? So, so what's our treatment going to be? Spine motion restriction, obviously, because we don't want to aggravate an injury that has occurred. And if you have vasogenic or neurogenic component, we went from a vessel that was this size on the right to a vessel now that is this size. Well, what do we know? If we have a vessel and we have systemic vasodilation, all of a sudden, what happens to the pressure? What happens to the systemic? Larry talked about this. What happens to the systemic vascular resistance? The resistance in that vessel, when all of a sudden that vessel loses its tone and it becomes very large. We can no longer fill that vessel with blood. We don't have enough volume to fill that vessel with blood to maintain a pressure. Well, if we don't have enough volume to fill that vessel with blood, because it dilated, what are the treatments? Well, there's two treatments. Fill the vessel and constrict the vessel. So the two components to your treatment in the spinal shock patient that has a vasogenic or neurogenic component where they're dilated is give them volume, normal saline, lactated ringers, an isotonic solution, okay? Push the volume and get a pressor on board, okay? Whatever pressor you're going to use. In this case, the best pressure that you can use is actually norepinephrine because it's predominantly alpha. You can use dopamine at a higher dose. You can use epinephrine too. Anything that has an alpha agent in it. We're not concerned with the beta, but you do want an alpha agent. But you do want a vasoconstrictor. You want to fill the space. If it's a smaller area, you might be able to control this just with volume. But you got to be careful too, because remember, their heart rate can increase. So you don't want to overload a patient, especially an elderly patient. You don't want to overload them on volume, okay? And all of a sudden now they're going into heart failure because they can't offload the preload you're putting in there. Now all of a sudden they go into pulmonary edema. Listen to their lungs carefully, constantly, carefully listen to their lungs. Always monitor their SpO2 and also monitor their end-tidal CO2, okay? All right. Now, incomplete spinal cord injury makes up about 50% of the spinal cord injuries that we're seeing in those 17,800 and some patients, okay? So incomplete spinal cord injury syndromes are a little bit different because it's telling you, right here, it's telling you the spinal cord is not completely injured. It is incomplete. That means a portion of the spinal cord is still intact. Okay, remember this? Okay, these columns up here, these are your pain columns up here, okay, in the front of the cord. Whoops. Those are your pain columns in the front of the cord. Right here, they're anterior. Remember, to test them, what do? We have to apply pain to the periphery, okay? And if we want to test the left side, we have to apply pain to the right. If we want to test the right side column, we have to apply pain to the left. These columns here, lateral columns, these lateral columns are your motor columns, okay? They actually take impulses down from the brain to the body, movement. How do we test them? We make the patient move. On the same side, if I want to test my right column, I make a move on the right. If I want to test my left column, I make a move on the left. These posterior columns carry light touch. If I want to test my right posterior column, I lightly touch them on the right. If I want to test my left posterior column, I lightly touch them on the left. Okay, you guys are ready for the clinical application now. How do we apply this now? All right, this is the important part. There are a couple. There are three main incomplete cord syndromes. One is an anterior cord syndrome, okay? So here's what I want you to do. I want you to pull out a piece of paper or whatever, or even on your phone, whatever you got. Some you could jot this down, but I want you to look at this anterior cord syndrome. And I want you to tell me in this patient's clinical presentation, that oranged out area, this oranged out area is the area of injury. This is common in a blunt trauma where you have an anterior vertebral artery that comes in this fissure here and runs up along this spinal cord and supplies the anterior portion of the cord with blood. If that anterior vertebral artery is compressed or lacerated or kinked or something of that nature, it'll cut off the blood supply and it'll cause this type of injury pattern. So in this anterior cord syndrome, clinically, how is this patient going to present when it comes to pain, light touch, and motor on the right and on the left? Okay? All right. I'll give you a second. Write it down. I'm going to have somebody tell me. I want somebody to tell me. I don't want to tell you guys. What's going to happen with this patient? How are they going to present with pain? How are they going to present motor? And how are they going to present with light touch in your clinical assessment? Anterior cord injury, common incomplete spinal cord injury. Okay, move on. This is another anterior cord syndrome. But notice that this anterior cord syndrome extended beyond the other anterior cord syndrome. So this is another presentation that is still an anterior cord syndrome. So this is our anterior cord syndrome B. How is this patient going to present on your assessment? What are you going to find in regard to pain, light touch, and motor on the right and on the left in this presentation? Remember, 50% of your patients have these incomplete cord syndromes. Actually, in the past, I read it was a lot more. I was shocked to find out today that they're saying 50%. So in the past, I had read it was a lot more. It was more like 70 to 80% of the patients. So, Okay, so you have an anterior cord syndrome. It's still an anterior cord syndrome, but this injury extended further back, further posterior into the cord. Same mechanism where the anterior vertebral artery is damaged. Okay? All right. Central cord syndrome. This is usually occurring in elderly patients that suffer some type of severe hyperextension injury. They have what's called a ligamentum flavum, and what happens is the ligamentum flavum presses on the center of the cord, and it actually causes injury, an injury pattern here. So what are you going to find as far as your posterior columns, motor columns, and your pain columns? Keep in mind these are your anterior columns, your pain, your motor, and your posterior, your light touch. What are you going to find in this patient in regard to pain, motor, and light touch? Again, if you get anything out of this lecture, this is it right here. Because if you get this, then you got your clinical assessment to the spinal cord injured patient. You're going to feel real comfortable with this. Okay, this is called a Brown-Sequard syndrome. A Brown-Sequard syndrome is typically a spinal cord injury that occurs in a lateral collision, a lateral crash, okay, where it's like a broadside crash and the injury pattern is occurring from, the lateral aspect of the body. The injury pattern here is on the left in the oranged out area. Remember, pain, motor, light touch. What clinical assessment findings are you going to find in this Brown-Sequard syndrome? If you have a patient in a lateral collision and they have a Brown-Sequard syndrome, how are they going to present? These, again, are your three most common incomplete spinal cord syndromes.
Come on, someone give Joe the answer.
Oh, I'm going to ask for him, Matt. Oh, I have
touch and motor with no pain.
I have a lot of confidence. You're going to control it, Matt. You got to pick somebody or something or whatever. All right. Okay, so these are them again. Okay, your anterior cord injury that is extended further back, your central cord, and your Brown-Sequard. Okay, I have these individually. Okay, Matt, go ahead, pick somebody. What clinical findings, if you were assessing this patient with an anterior cord syndrome and you're doing your neurologic exam, what are you going to find? Come on, somebody.
No hands up? I'll just pick one then. Let's see.
Oh, come on, somebody volunteer.
I'll try.
Okay, who is it, Lauren?
Yeah, I'll try.
Oh, Lauren, you got this, come on.
So if you've taken out the anterior part of the cord is your pain.
Mm-hmm.
So you would have no pain sensation on either side.
Okay.
You've hit both. Lateral, because it starts extending into the lateral portion, that is where you have your motor. So you would have motor discrepancies on both sides.
But again, here, Lauren, don't, this is nothing. Here's your motor track here and here's your motor track here.
Oh, they're higher up. Okay.
Yeah, this is your motor track here and here. This is not your motor track. This is not your motor. These are cell bodies. So your motor tracks aren't affected.
I thought your one was. Okay.
Oh, no, just this one. Just this one. We have an anterior cord syndrome, and this is the injury pattern right here.
Your anterior cortical spinal tract would be affected, wouldn't it?
Yes, these are your
left side.
Yes. So this is in your assessment finding. You're not going to have pain on your left, right? Because this controls the left. You're not going to have pain on the right. They're not going to respond to pain. But they're going to be able to move if this has no injury, right? On the left.
Okay. With the one diagram, the anterior cortical.
No, we're not there yet. That's next. Look,
Okay.
That's our next one. We're not there yet. Here, we're doing this one. This is what's injured. My spinal thalamic tracts are injured. So
Right.
in my neurologic assessment, I'm assessing the left side, Lauren. I'm assessing left side. Can they feel light touch?
They
Anybody
should
in
be able to
particular
feel
you want me
all
to
the
give
light
next
touch.
to?
Exactly. They're going to be able to feel all the light touch. Should they be able to
All
move?
light touch. No, they should be able to move.
Will they be able to feel pain on the left?
No.
No. Will they be able to feel light touch on the right?
Yes.
Will they be able to move on the right?
Yes.
Will they be able to feel pain on the right?
No.
Okay. Here's your patient. Remember those of you who said, well, if my patient can feel me touching, they surely can feel pain. Well, you just missed an anterior cord syndrome. Because the only thing this patient is going to present with, they can't feel pain. And if you never assess for pain, you don't know that they lost that sensation. So, okay, Lauren, you're right. So they can't feel pain on the side. Yes.
I do have a question. On the slide before this,
Uh-huh.
the anterior cortical spinal tract was in the affected area. It's lower.
Okay, let me go to that one. This is the next one.
No, the one before you started the.
That was it.
No, I think you're going the other way.
No,
Because we didn't see that.
I'm going back. There.
One more.
Oh, it was this
Back.
one.
See there. No, back to the.
Oh, no. These are your motor tracks here. I see. No. Yeah. No. These are your pain track. This is very elementary illustration. Pain, motor, light touch. Okay. Thank you though. Okay, Lauren, since you're on, do this one now. This is the one you wanted. So what's this one?
Yeah, it would be still no pain in the right and left. You would have intact light touch in all areas, and you would have motor of being affected in both sides.
Right. So you would have no motor response on right and left. The patient will not be able to feel pain on the right and left, but they can feel you touching them.
Correct.
Again, that would confuse the hell out of a lot of people because they think I'm pinching them and they can't feel it, but when I touch them, they can feel it. This is another anterior cord syndrome with just an extension of the injury pattern. Okay, thank you, Lauren. How about this one? Yes. How about this one? This one's a little bit more confusing. This is your elderly patient. Okay, let's do this. Look at this. Okay, spinal thalamic tract. Not impacted, right? Okay, anybody want to volunteer for this one? Come on. Not Lauren again.
I see a hand up. Who's got their hand up? Roman?
Okay,
Roman,
Joe.
All right, Roman, go for it, brother.
You got pain in both sides.
Okay.
You're gonna have some deficits in movement and light touch on both sides.
So pain is intact in both extremities, but I'm going to have some deficits to my motor response because I got some injury pattern, and it's to the medial aspect of the track, and I'm going to have some light touch dysfunction too. Although remember I said light touch is carried by multiple independent tracks, so you might still have light touch intact. But the main thing we're going to find is this odd motor presentation. Now here, let me go back. Whoops, let me go back here. Look at this right here. Notice cervical is most medial, thoracic, lumbar, sacral. And if you look at this injury pattern here, what is injured the most?
Uppers.
Yep, exactly. Remember the old lady who met you at the door, couldn't move her arms, but is able to walk around the house? This is her. Because when you injure the medial aspect of the cortical spinal tract, that's when you lose motor function in the upper portion of the body. As you extend out and you go more lateral, that's where you lose the lower body. This patient is going to present with severe weakness or they're going to present with paralysis to the upper extremities, but intact lower extremities. Tell me that's not going to confuse the hell out of somebody going, well, there's absolutely no way this would be a spinal cord injury if they can walk around the house, but they can't move their upper arms. Excuse me, absolutely is. How about this one? Somebody want to give it a shot? Brown-Sequard syndrome.
That's going to be deficit on the motor deficit on the left side of the body, and loss of sensation on the same side as the injury.
Okay, on the left side. Okay.
Yep.
So left-sided light pain lost on the left, motor function lost on the left. What about here? This is my pain track. What side of the body?
It's going to be on the right side, same side as the injury.
Right side. And then I'm still going to have light sensation on my, I'm going to read right, and I'm going to have motor movement on my right, and I'm going to have pain sensation on my left. Exactly. So in this presentation, I have a patient who has no motor movement on the left, can't feel light touch on the left, but can feel pain on the left, can feel light touch on the right, can move on the right, but can't feel pain on the right. And again, that would confuse the hell out of somebody, but again, that is an incomplete spinal cord injury. That's a spinal cord injury. This patient needs spine motion restriction. Make sense? That's your clinical application. If you know that, if you could do that, then you know what? Your clinical assessment should have become extremely clear to you at this point. Okay, there's what's called a posterior cord syndrome. This is actually fairly rare in injury. This could result from a hyperflexion injury. But if you have a posterior cord injury, you lose your light touch. But keep in mind that multiple independent tracts carry light touch. So it's a little bit of more of an injury. But if you have a patient that has pain, has motor movement, but they can't feel light touch, you immediately would know then that's a posterior cord injury. And there's a posterior cord syndrome. It's just nowhere near as common. And then there's a conus medullaris, or it's called a cauda equina syndrome more than anything. There's a conus medullaris syndrome too, but they're basically almost the same thing. And that's where you have injury to that portion of the cord. It's below the spinal cord itself, but the conus medullaris is that point where it comes out, where the spinal cord ends, and you have that group of nerve roots, and that's injury to those nerve roots. And that's below the injury below the level typically of L1, L2, where the spinal cord is ended. Loss of sacral root function, foot movement, Achilles tendon reflexes are gone. A lot of times bowel and bladder dysfunction occurs, sexual dysfunction occurs, and so forth. These are syndromes. But the most common would be the anterior cord syndrome, the central cord syndrome, and the Brown-Sequard syndrome. All right, clinical assessment. Most important. I think right now you guys got it, okay? What is this person going to complain of right here? Somebody tell me, what's going to be this patient's number one complaint?
Right arm pain.
Yeah, pain, right? Right arm pain. Why? Because they have what? A fracture, right? They fractured a bone. What's going to be their number one complaint? Pain. How about this guy right here? Left shoulder. What's this guy going to complain of? Somebody?
Right shoulder looks dislocated.
Yeah, it's dislocated. So what's going to be his number one complaint, Lauren? It what?
Pain.
Pain. It hurts because it's dislocated. It's a dislocated joint. It hurts. Okay? What does that mean? If you have a patient who has a vertebral injury, a vertebral injury is a bone injury or a ligament injury or a dislocated disc. What's the number one complaint of the patient?
Neck pain.
Pain. And if they don't have pain, you palpate the vertebral column. And you palpate it lightly all the way down from the cervical region all the way down to the lower back. And if you elicit any pain, it's obviously called tenderness. That is another indication that they may have a vertebral injury. If they have any pain, any tenderness, or you feel any anomaly, they get spine motion restriction. This is as simple as this. How do you test for a vertebral injury? Are they complaining of pain? If they complain of pain, you suspect a vertebral injury. Do they have any tenderness? Do they have any anomaly on your palpation or tenderness on palpation? They got a vertebral injury. It's as easy as that. Okay. All right. Now your spinal cord assessment, remember, is neuro tissue. How do we test the spinal cord? You guys already did it. You test for motor, you test for pain, you test for light touch. You already know, you know where you're testing, you know why you're testing. The motor exam is the most dependable. It's more dependable than pain and light touch, but again, you're going to do all three in all patients. Okay, very quick, very quick exam. This neuro exam will take you seconds to do. So you arrive on the scene, you don't know if this patient has a vertebral injury or a spinal cord injury, and you get on the scene. So all you're going to say is, ma'am, if the patient is alert, the patient is oriented, the patient is responding, you say, ma'am, I want you to keep your head still. I want you to keep your nose lined up with your belly button. I don't want you to move it, okay? I want you to go like this for me and have her flex both her arms at the elbows. And if she's able to do so, you're checking the motor track on the right side, and on the left side is C6. And then you go and then go like this at C7. So you go, ma'am, go like this. And she goes like this. I've just redundantly checked C6, C7 motor track, right side, left side. Okay. Then the next thing you're going to do is you're going to say, go like this. And you have her abduct her fingers. And when she abducts her fingers, I'm testing the motor track at T1 on the right, motor track at T1 on the left. As simple as that. The next thing I'm going to do is I'm going to have her hold her hands out, and I'm going to say, don't let me push your hand down. I'm going to support underneath the hand, and I'm going to push the wrist, and that redundantly checks C7 again. Okay, so I get on the scene. Ma'am, I want you to keep your head, your nose in line with your belly button. Okay, don't look at me. I want you to just keep your head in line. I want you to go like this. Okay, good. I want you to go like this. Okay, good. Don't let me push your hands down. Okay, good. Now, I just tested what? C6, C7, C7, T1 redundantly, motor tracks. Now I go down to the feet. I put my hands on the top of the feet and I say, pull back on my hands. Okay, great. I just tested L5. I say, now I put my hands on the bottom of the feet and I say, push down on my hands. Okay, great. I just tested S1, S2. I'm done with my motor exam. If I find any abnormality in my motor exam, there's weakness, there's a lack of movement, I suspect that that motor track is injured, and I then call it an possible incomplete spinal cord injury. And what do? SMR. SMR. Any abnormality in my motor exam, as slight as it might be, I suspect an injury to a motor track, and I do SMR. Okay, I do that again. Remember, C6, C7, T1, C7, pull up, push down. Okay, that's it. L5, S1, S2. That's my motor exam. Take me seconds to do. Then when I go, the anal wink, sacral sparing. Yeah, don't check for this. But again, the lowest level of the cauda equina that you could test is at the level of the anus. And what the anal wink is, you tell your brand new partner to check for an anal wink. They get down, they pull the cheeks apart, and they're looking for the anus to wink at them. You know, I don't know. You might get a date out of it, but other than that, it's not what they're really looking for. An anal wink actually is they preserve anal tone. And the way you check for it is you take a gloved hand, you lubricate it, you stick it in the anus. If the anus still has tone, it's called sacral sparing. What that means is that there are sacral nerves that are still intact, and it's not a complete spinal cord injury. That's an extremely important sign. Don't do it in EMS. You'll probably go to jail if you do it. In your sensory exam, you have to test at 2 levels, okay? And you want to check for any abnormal findings, any weakness, numbness, paresthesia, like tingling, radicular pain, like electric pain, shooting pain, loss of sensation, loss of pain, loss of light touch. Any of those, you have to suspect that you have an injury either to a spinal thalamic tract or a posterior column, and you're going to do SMR. But the way that you're going to do your light touch and your crude pain, your pain, is what they really recommend is that you take one of these old style wooden Q-tips and you actually break the Q-tip in half. And what you have on the one end is a cotton end you use to do the light touch, and then you use the broken end to actually check for pain. Now, again, when you're doing this, have your patient close their eyes. Now, if you check for light touch and pain in the hand and they're able to feel it, then you're done. You don't have to do anything further. If they don't feel it there, you can then move your way up the extremity, both upper and lower extremities. You do the same thing, and you just document it. You don't have to get into, well, this is a dermatome at the level of whatever. You don't have to. All you need to do is say that the patient failed to identify pain in the left hand. However, the patient was able to identify pain at the level of the shoulder or whatever it would be. But all you know at that point is that they have an abnormality with pain or light touch. If there's any abnormality in your test, any numbness, any tingling, you have to suspect that they have some type of neurologic injury, and you're going to have to go ahead and do spine motion restriction. Reliable patient, the patient got to be reliable. If they have a Glasgow Coma score less than 15, they're considered unreliable patient. If they're in an acute stress reaction, meaning that this patient just crashed their car, this is not a good time to do this neuro exam, because what do we know? They got a ton of endorphins and enkephalins circulating around. Endorphins and enkephalins are morphine-like substances, and what do? They blunt the patient's response or the sensation of pain. You got to wait until this patient calms down. Once this patient calms down, you go ahead and you do your assessment. If the patient can't communicate, then you do SMR, because you don't know how reliable this exam is going to be. If they have a traumatic brain injury, you're going to do SMR because you expect this patient to be not reliable. If they're intoxicated, you're going to do SMR because they're an unreliable patient. This is interesting. If they have a distracting injury, if this patient has a peripheral fracture, like a humerus fracture, radius fracture, ulnar fracture, femur fracture, tibia, fib, that pain is much more painful than that of a vertebral injury. So this patient will complain of pain to that extremity and typically will not complain of pain to the vertebral column. If they have a distracting injury, you really should do SMR with this patient, and it could be very simple too, okay? So now spinal mobilization versus spine motion restriction. As Matt said, you know, some of those things we taught you, like, oh my God, this is terrible. Well, that is terrible. And this is terrible. You would never do this to a patient. Or you remember the synchronized backboarding. Okay, 1, 2, 3, down, 1, 2, 3. This is crazy. It's not that crazy anymore. School bus accident. Everybody, all these kids sitting around. Hey, if I was on a school bus and got in an accident and they was like, any of you injured? Yeah, I'm injured. I want to go to school. I'd rather go to the hospital, man. That'd be a lot more fun than going to school. A lot of this stuff, you're like, this was nuts. This is so wrong. It's not that wrong anymore. Past practice, this concept of complete immobilization, total bullshit. You can't do it unless you're going to put your patient in concrete. Evidence against backboards. I'm going to go through this relatively quickly because we only got about, about 11, 13 more minutes, but whoops. All right. So long backboards are commonly used to attempt to provide rigid immobilization. We know that can't be done. It's never been proven. The benefit has never been proven. And these, again, are all studies that were done. National Association of EMS Physicians, there is strong historical, but no scientific evidence to support spinal mobilization. We've been doing this for how many years? We've never really had any evidence that said it actually worked or did anything. All these studies were based on healthy people and cadavers. You know, backboards are still being used as movement devices. You can move patients with them. They're movement devices. But you know what? Once you get them to the cot, you take them off the backboard. You can still use them for rapid extrication. You can still use them to move patients. But once you get them to the cot, you take them out. The KED, take it out the back of the station, build a fire, get the fire going, throw the KED in. You can piss on it because that's pretty much as good as it is. You manipulated your patient more trying to put this damn thing on than what you did if you just would have said, can you get out of the car? Okay. How about this? Look how proud they are. Look at this patient. This patient is sunk into the ground, hyperextension of the neck. This is crazy. This is nuts. The head immobilization device, you can see these, where the patient is down. It's just, this stuff is crazy. Complications of spinal mobilization. These are studies. Doubled mortality rate for patients who are immobilized. Siri. More movement of the spine when being immobilized by EMS than if the patient self-extricated. I mean, you got to agree with that. We're trying to put this KED on to get these patients on. We're like, oh man, Okay, we're moving them around, and we're, manipulating their head, their neck, their arms, their body, trying to get them out of the vehicle instead of just saying, you know what, keep your head in a neutral aligned position, put your feet on the ground, and step out of the vehicle for me. Hell of a lot easier. Okay. Patients immobilized in a supine position are unable to control their own airway. It's true. Patient vomits, blood, secretions. They're strapped to a board with their head straight in a supine position. They can't clear their own secretions. They're prone to aspiration. Healthy non-smokers had a 15% reduction in pulmonary compliance. Their ability to breathe on a backboard. Healthy people. Okay, take somebody with a chest injury, put them on a backboard. 33% of all back pain and trauma is due to spinal mobilization. They didn't have any pain at the scene. Now they got to the emergency department and they're laying there for an hour. Now they got a tremendous amount of pain. Has nothing to do with the injury. It's all about them being on that hard board. How do they relieve the pain? Got them off the board. We talked about this. Where do you store the backboards? Typically in outside compartments. If it's a day like today and you're running calls, that backboard is going to be cold. It might be 40 degrees, 50 degrees, the board itself. Now what do? We put that patient on a cold board and we expose the patient. Now we make them hypothermic, because they're actually conducting their heat from their body to the board. And what happens? Coagulopathies. I mentioned this before. We know that. They decrease the body core temperature. They found backboards will decrease the body core. Decubitile ulcer, look at this. It only takes a pressure of 70 millimeters of mercury over 2 hours to start causing tissue infarction and ulceration. An adult patient put on a backboard, their sacral pressure is 233, more than 3 times. Thoracic pressure is 83. Start causing tissue infarcts, okay? People in a backboard or supine position on ambulance stretcher are far more likely to experience motion sickness, vomiting, and aspiration. Why? Because you got their head strapped down in a supine position. Collars, cervical collars, may exacerbate cervical spine injury instead of protecting the patient from secondary injury. Many of the collars aren't fitted right. If they have ankylosing spondylitis, they have an extreme risk. These are about 5% of the patients. Look at this. By putting a cervical collar on and putting it on, and a lot of times they're put on too tight, it may increase intracranial pressure by 4.6 millimeters of mercury. Because of the cervical collar, it doesn't allow the venous flow to drain appropriately, and it increases the intracranial pressure. There's a mean increase in ICP by 1 millimeter of mercury by putting a patient supine on a board. Your intracranial pressure is about 10 millimeters of mercury. I have it down here, okay? We're talking about 4.6. That's significant, okay? And what do? Decrease cerebral perfusion pressure if doing that. If the ICP is greater than 15, placing a patient in spinal mobilization and increase ICP by a mean of 7. So we're talking about lowering cerebral perfusion pressure by collars and putting patients supine on a backboard. I'm going to skip this. Larry actually talked about the mean arterial pressure and so forth, but for sake of time, I'm going to skip it. A cervical collar, a correctly applied cervical collar, creates an unnatural separation of spine by as much as 11.3 millimeters, enough to cause a secondary spine injury. A cervical collar increases spinal motion in high C-spine injury, C1 through C4. A cervical collar causes separation of C1 and C2, stretching the spinal cord. The collars can cause pressure sores, lead to pain, lead to discomfort, okay? A cervical collar that is applied properly, okay, leads a lot of times to airway management problems. Mouth opening is restricted by 25%. Aspiration is more common in vomiting. And then respiratory restriction, especially when used with a spine board because of the poor pulmonary compliance. Let me tell you one thing. If you have a cervical collar on your patient and you're struggling to get an airway, get the damn cervical collar off and get your airway, okay? Because the cervical collar, a lot of times, is much more of a hindrance than it's actually doing anything. Cervical collars were designed to reduce axial loading. That was it. This nonsense is done. We're done with this. You're not going to do this anymore. There is actually consideration to go back to soft collars. And you know what the soft collar does? We always laughed. We call them neck warmers. And he's like, what's that soft collar do? You know what it does? Reminds the patient not to move their head and neck. That's what it does, primarily. Okay, I'm going to skip through these. These are just the recommendations. These were American College of Surgeons, and this was NAMSP, and this was all their stuff basically supporting what we're doing. This is your protocol right here. And this is the protocol basically that says your spine motion restriction consists of a cervical collar, the cot, and 3 straps. That's spine motion restriction. And that is if your patient has a suspected vertebral or spinal cord injury. If you went through your assessment in a reliable patient and you found no neurologic deficit and you found no pain, no tenderness, no abnormality to the vertebral column, they don't need anything. They don't need to be put on a backboard. They don't need a cervical collar because you now again, we went to more ruling in than ruling out. If you do that assessment that we just went through and you found no abnormalities and you know your patient is reliable, they don't need anything. But if you have any abnormality in motor or sensory function or any pain or tenderness or abnormality, they get spine motion restriction. But what is that in Trumbull County? A cervical collar. The cot provides adequate stabilization with 3 straps. No backboard, no reeves, no scoop. Okay, just going to go through these quickly. So this is actually a patient that you find ambulatory at the scene. How many times you get on the scene? How many times have we gone to a scene, the patient's been walking around, they're in the back of the police car, and we say, sir, can you get out of the police car? All right, well, we're going to have to go ahead and immobilize you. All right, well, come on. Can you get in the back of my ambulance? Hang on. Can you get back up again? Let me put this backboard down. All right, go ahead and lay back down on the board. Wait, can you sit up again? Let me put this collar on you. Go ahead, lay back down again. It was like nuts. It was ludicrous what we were doing. We have a patient that's ambulatory at the scene. Just talk to the patient, get in front of them and say, look, just keep your neck and head in line. Your nose in line with the umbilicus. Don't move it, okay? I don't want you to move your head. I'm going to do a simple assessment on you. You go through, you palpate the vertebral column. You ask the patient if they're having any pain. You palpate the vertebral column. You're checking for tenderness. You're checking for any abnormalities. If there's no pain, no tenderness, no abnormalities, then you're going to say, I'm going to rule out a vertebral column. You're then going to go through your pain, your light touch, and your motor assessment. And if the patient complains of or has intact motor function, intact sensory function, pain and light touch, then you know what you're going to do? You're going to tell the patient, okay, all right, come with me. You're not doing anything. No collar, nothing. You're going to put them on the cot and transport them or not transport them, whatever you're going to do. No backboards, no collars, nothing. You just ruled it out, okay? Now, this is applying spine motion restriction in an ambulatory patient. This is the patient that has either vertebral pain, tenderness, an abnormality, or some type of dysfunction in the neuro exam. You're going to actually have your part. You're standing. Look, nobody's doing holding the head. This patient is alert. This patient's aware. You're explaining to the patient, I want you to keep your head in a neutral inline position. Keep your nose lined up at your belly button. Don't go forward. Don't go back. And your partner is going to come up behind the patient and apply a cervical collar. You're going to take the cot behind the patient. You're going to instruct the patient to sit back down on the cot. You're then going to actually keep the patient, support the back, keep the head and nose in line with the umbilicus. You're going to assist the patient, bring the legs up onto the cot. The EMT or paramedic in the back, advanced EMT in the back is going to support the patient. And then you're going to go ahead and you're going to lower the patient to the cot and you're going to strap the patient in. There are a lot of systems that will allow the patient to actually be transported in a semi-Fowler's position too. Like if the patient is not comfortable lying in a supine position, you can transport him in a semi-Fowler's position, okay? This is self-extrication. You arrive on the scene. This patient has been involved in a crash. You want somebody to approach the vehicle from the front. This is a little extreme, like, listen, you asshole, don't move your head. No, I don't know what he's doing there. Like sizing something up there. I don't know, he's probably a funeral director or something. But he tells the guy right here, he's like, look, I don't want you to move your head. I don't want you to move your neck, okay? That's the most important thing. Keep your head and neck in line. He's then going to approach the patient. He starts his assessment. He's assessing the vertebral column for any pain, any tenderness, any abnormality, okay? He obviously found something in his assessment. because either it's in his neuro assessment or his vertebral assessment, because now he's telling this patient, you look at me, don't turn your head, don't move your head. His partner's going to apply a cervical collar. Then what they're going to do is they're going to have the patient pivot out, pivot around, keep his nose in line with his umbilicus, pivot out of the vehicle, stand up, okay, take a couple steps, and then they're going to bring the cot behind the patient, and then they're going to actually have the patient then lie down just like did in the other situation, okay? So again, hopefully you walk away from this and you go, man, okay, this made it a lot easier because I know one thing. I assess the vertebral column for pain, tenderness, and the abnormality. If I find anything that gets spine motion restriction, collar and cot, okay, I can move them on the backboard, get them off the backboard because the backboard causes problems, okay? If they have any abnormality to pain, light touch, or motor, any paresthesias, any numbness, any tingling, any radicular pain, anything like that, they get SMR, okay? If they have none of that and they're a reliable patient, no distracting injuries, no drugs, no alcohol, nothing of that nature, I don't do anything. I do no spine motion restriction. Okay, questions? Any questions? And I want you to notice, Larry and Matt and Justin and Connor and all you bastards out there that say I go too long. It's 8 o'clock.
Did you say Connor?
Oh,
Connor, Justin, Larry, Matt, Jen, Lauren,
on. Or I didn't hear what you said.
Connor, all hollering.
Doesn't anybody have any questions for Joe?
Any questions?
No, God, no.
Who the hell was that?
Like PTSD of paramedic school all over again.
Oh man. Well, again, I hope this, gives you a lot of comfort and confidence in your assessment. We don't need to be doing this to all these people out there. And be smart about it. Do a clinical exam.
Right. I was on Romper.
Nuh-uh.
I got on Romper. I did
All right.
so.
No, you were famous.
I'm done.
Thanks, Joe.
You are welcome, Matt.
No, I really appreciate it. That was a great refresher and a great polishing everybody up on the injuries to the spinal cord. I really appreciate that, and emphasizing the changes in our assessment and the changes in our treatment. I appreciate it, especially since
You're
most
welcome.
came from you.
And again, I will get this to you guys. I'll post it on my Google site. You guys can take it down and post it. So it'll be available too. And again, I'll do it as a PDF and an actual PowerPoint. So if anybody, wants to use it in your station for, continuing ed or whatever, feel free to use it. You can use the PowerPoint. So just make sure the information's accurate. That's all. If you have questions, let me know. I'd be happy to, Jen Arendis, 801. I still went over. Damn it, Jen. I was really trying. Anyways, I'd be happy to answer them. If you got questions, if you're going to do this and you got questions, please just email me. I'll get on the phone with you and we can go over it just to make sure the information's accurate. That's all. Really pushing this assessment too, clinical assessment. Mechanism of injury really doesn't tell us much at all. So anyways, all right. Thank you. Thank you, guys.
All right, thanks, Joe. We'll be just a couple minutes setting up Peggy, who's going to be talking about hemorrhage and hemorrhage control. So go ahead and take a couple minute break. Please throw your hands up so that we can take attendance. This will be a very short break.
Ready?
I think so. Go ahead.
Is the camera on?
Yep, it is.
And how do you click through the slides?
Just, yeah,
That
just
one.
click, yep.
Sorry guys, technical difficulties here.
Always.
Are y'all ready? So I'm Peggy Higgins. I'm the new trauma coordinator here at Trumbull Regional, and I feel very privileged to have the honor to speak to you guys this evening. We're going to talk about hemorrhage control for EMS provider, and I was just telling Matt and Larry that I'm probably not going to tell you guys anything that you don't already know. You guys are probably going to be able to teach me something, so please let me know if you have any comments or questions as we go through. So some of the things that we're going to review here are categories of hemorrhage, just some basic knowledge of capillary venous and arterial hemorrhage. We're going to talk about some different types of ways to assess life-threatening hemorrhage, looking at CABC, MARCH, the trauma triage of death, stages of shock. Of course, anytime we talk about hemorrhage, we're going to have to talk about shock, and the ACS grading of progression of hemorrhage shock. Let me just do this. There we go. We're also going to talk about some different hemorrhage control applications, and then we'll just talk about a couple different special populations when it comes to hemorrhage. Some of the stats, traumatic injuries are the third leading cause of death in the U.S. and the leading cause of death for ages 1 to 46. Several traumas, severe traumas result in over 5 million deaths a year worldwide. Hemorrhage accounts for 35% of those deaths from these traumatic injuries, and it's the major cause of preventable death after injury occurs. Up to 1/2 of the deaths result from hemorrhage prior to reaching definitive care, and this is where you guys come into play. In 2015, the National Trauma Institute estimates that hemorrhage accounts for 35% of pre-hospital deaths and 40% of deaths within the first 24 hours of injury. Let me just move this real quick. Stop the Bleed initiative was launched in 2015 in response to recent mass casualty events, and it's modeled after the standard military procedures on the battlefield, with the goal that it becomes as commonplace as CPR and AED training to save lives. So with the capillary bleeding, some of the injuries that can cause this are just minor cuts, abrasions, skin tears, lacerations, road rash. It's a most common form of bleeding. It can also be the most painful, but it's also the easiest to control. It's characterized by oozing and seeping blood. Venous bleeding can also occur from lacerations, deeper punctures, degloving, or amputations. It's characterized by a steady flow of dark red blood. It's easier to control than arterial because it lacks the force of the arterial system. It can be life-threatening when large veins are injured and blood loss is severe. Then, of course, what we're most worried about is arterial bleeds due to lacerations, punctures, amputations. It's characterized by rhythmic pulsating or spurting bright red blood. Look for blood that's soaking clothes or sheets or pooling on the ground. It's difficult to control due to the force with which the heart pushes blood into the arterial system. And management arterial bleeds are time sensitive and should be considered a medical emergency. So as far as assessment goes of hemorrhage, we can look at CABC. So across the room, observation should be your first assessment, whereas C is the catastrophic hemorrhage. That needs to be addressed prior to anything else. A for alertness and airway. Unresponsiveness may be due to hypovolemia and not necessarily head trauma. So consider that. Uncompensated shock or blood loss of 30 to 40% may occur prior to unresponsiveness. The use of alcohol drugs may also mask shock-induced changes in level of consciousness and early shock. Breathing and ventilations, increased work of breathing may indicate compensation for early shock. And for circulation, you're going to want to make sure that you inspect for active bleeding, skin color, temperature, moisture, any distended abdomen or unstable pelvis. Auscultate for diminished breath sounds. Assess for pneumothorax, hemothorax, muffled heart sounds, assessing for pericardial tamponade. Palpate central pulses. If they're bounding, that may indicate increased cardiac output. Peripheral pulses with a strong central pulse and a weak peripheral pulse could be indicative of shock. And again, tenderness or rigidity of the abdomen or instability of the pelvis may be signs of occult hemorrhage. The U.S. Department of Defense's Tactical Combat Casualty Care teaches MARCH, where M is for massive hemorrhage, so control life-threatening bleeding first. Airway, establish and maintain a patent airway. Respiration, decompress suspected tension pneumos, and support ventilation and oxygenation. Circulation, vascular access, administer fluids, and head injury, hypothermia. Prevent or treat hypotension and hypoxia to prevent worsening traumatic brain injury, and prevent and treat hypothermia. The trauma triage of death is important as well. Hypothermia, it impairs thrombin production and platelet function. Acidosis impairs thrombin production and other coagulation factors due to decreased pH, elevated lactic production, and increased space deficit. It can reduce various coagulation factors by 40%. Coagulation is present at the time of ED arrival on up to 25 to 35% of trauma patients, demonstrating that coagulopathy occurs within minutes following the injury, which was surprising to me. This can lead to DIC, as well as multi-system organ dysfunction and higher mortality rates. With whole blood loss, clotting factors are depleted. Replacement with PRBCs and hemodilution with normal saline can also further dilute the blood's ability to clot. And that's why with like your mass transfusion protocol, here we do 4 red blood cells, 2 FFPs, and 2 platelets. Some other systems may be different, but that's what we do here. So the stages of shock. So stage 1, compensated shock. Compensatory mechanisms begin in response to poor tissue perfusion. There's a narrow window of opportunity to intervene here and restore perfusion. There's an increase in the sympathetic nervous system response. So vasoconstriction begins to shunt blood to the vital organs. You may assess a narrowing pulse pressure due to peripheral vasoconstriction. The diastolic is rising while the systolic is may be within normal range. You may assess tachycardia, and that's due to catecholamine release, tachypnea. Their mentation may be anxious, lethargic, confused, or restless, and decreased urinary output, which we may not often see in the beginning of meeting this patient. Stage 2, decompensated or progressive shock. So compensatory mechanisms begin to fail and are unable to support perfusion. There's an aggressive and immediate interventions may occur as acidosis develops, leading to tissue death and organ dysfunction. Deterioration of a level of consciousness, so they may be obtunded or unresponsive, decreased systolic blood pressure, again, narrowing pulse pressure, heart rate will start to go up, heart rate greater than 100, weak, thready peripheral pulse, rapid, shallow respirations to correct the acidosis, and cool, clammy, cyanotic skin due to shunting. When I'm assessing a patient, one of the first things that I notice is skin. So I think that can be oftentimes your best assessment point, is describe. And for me, that's with a cardiac patient, a respiratory patient, you know, hemorrhage, septic, whatever. That can be oftentimes one of your the greatest things that you can look, pull down their eye, look at their mucous membranes, have them stick out their tongue, check for that, because with patients with Hyperpigmentation, you may not often notice if they're pale, you know, blanch their fingertip and do cap refill. So that's one of the tools that I often use. Stage 3, irreversible shock. So despite aggressive resuscitation, it is difficult to restore tissue perfusion, correct coagulopathies, and minimize organ damage. There's minimal ability to reverse morbidity and mortality. Profound hypoperfusion leads to systemic inflammatory response syndrome, the release of cytokines resulting in vasodilation, increased capillary permeability, and coagulopathy. There's an increased permeability of the pulmonary capillaries, leading to non-cardiogenic pulmonary edema, alveolar collapse, and decreased pulmonary blood flow. Tissues and cells become ischemic and necrotic, resulting in multiple organ dysfunction. The lungs, heart, and kidneys are first to be affected. So for stage 3, some of the signs and symptoms that you may see, they may be obtunded, stupidous, or comatose, hypotension and heart failure, bradycardia with possible dysrhythmias, decreased and shallow respirations, pale, cool, clammy skin, severe acidosis, and some coagulopathies, petechiae, purpura, or bleeding. The ACS developed a classification system for the progression of hemorrhagic shock, and I thought that this was interesting because it can tell you the volume that you can expect in each category. So for class 1 shock, loss of less than 15% of total blood volume. So that would be for, you know, an adult with 5 liters, 6 liters of total blood volume, up to 750 mLs loss. They may still have normal vital signs. Mentation may be slightly anxious, and the fluid replacement that you would use would be crystalloid. For class 2 shock, the blood loss of 15 to 30% of total blood volume. So that would be between 750 mLs to 1500. The heart rate is, you know, fairly tachycardic. Nomotensive, pulse pressure begins to narrow, heart rate and respiratory rate is elevated, and they're mildly anxious. At this point, they could use crystalloid or blood products. I was thinking about a patient at a facility that I had worked at who had a routine surgery and was admitted, and she overnight began vomiting blood, and the nurse played it off, and the patient continued to vomit blood all night long. The doctor came in the next day, and the mom kept bringing this to the nurse's attention and to the doctor's attention. Well, they thought because she was tachycardic and anxious that she may have had a PE, because, you know, that's a risk factor after surgery. So they brought her down to the ER and to get a CAT scan, and they laid her on the CAT scan, and she coded and died. She had vomited about 2 liters of blood overnight, and then another 2 or 3 liters in the ER. So she vomited her whole total blood volume. And, you know, that's just a nurse who didn't recognize the volume of blood that this, you know, patient was losing and didn't react to that. Class 3, blood loss of 31 to 40% of total blood volume. That would be 1,500 to 2,000 mLs of blood loss. Heart rate 120 to 140. Systolic now drops below 90. Narrowing pulse pressure. Respiratory rate 30 to 40. Their mentation, it becomes confused, anxious, and at this point they would need to receive blood products. And then class 4 would be a blood loss of greater than 40%, which would be greater than 2,000 blood loss. Heart rate's greater than 140. Systolic less than 90. Narrowing pulse pressure, respiratory rate very tachypnic. Their mentation would be confused, lethargic, and at this point they would need a massive transfusion. So some of the hemorrhage control, direct pressure, any area with obvious bleeding and is compressible, requires direct pressure first. It's effective for external bleeding, requires firm continuous pressure, use 2 hands, or have your patient assist you by holding pressure if you have multiple patients. And if you do that and your patient is able to do that and then suddenly isn't able to do that, that would be a good indicator that they've lost their mentation and may be deteriorating. Wound packing and pressure dressings, any area with obvious bleeding that is non-compressible. So this would be truncal or junctional wounds, your groin, gluteals, pelvis, perineum, axilla, and the base of the neck. Placing gauze into the wound creates pressure against the bleeding vessels and encourages clotting. And then the hemostatic dressings are preferred. Don't pack wounds of the abdomen, chest, or open skull fractures. Pelvic binder is useful if you suspect a pelvic fracture. And of course, be cautious of any sharp fractures, edges, or foreign bodies when you're packing wounds. The hemostatic agents, gauze incorporating chemicals designed to promote rapid blood coagulation. It establishes hemostasis by concentrating coagulation factors, adhesion to tissues, and delivering coagulant factors to the hemorrhage site. Apply the product and hold direct pressure and keep tourniquet in place. So a couple options, Celox products, the quick clot gauze uses the kaolin and aluminum silicate to promote coagulation. Doesn't have any side effects, and the Shido-based gauze. Tourniquet, early placement of a tourniquet for uncontrolled bleeding will minimize the likelihood of mortality from hemorrhagic shock. If direct pressure fails, a tourniquet should be placed 2 to 3 inches proximal to the wound, sparing joints and directly on skin if possible. The tourniquet must be completely and consistently occlude arterial blood flow. The pressure required to occlude blood flow in a limb increases exponentially with circumference of the limb, so more tension is required to occlude an arterial bleed in the leg than of the arm. And the effectiveness of the tourniquet is, one way to assess that would be cessation of blood flow, not the absence of distal pulses. If blood flow continues, attempt to reposition, tighten, or place a second tourniquet. And then mark the time of placement if possible. If your transit time is less than 1 hour, then leave the tourniquet in place, which I think is probably for most people. If it's greater than 1 hour and there is an isolated injury and the patient has stable vital signs, the author in the article that I quoted here said you could do a trial of tourniquet conversion. Have hemostatic agents and dressings ready to apply direct pressure. If bleeding becomes uncontrolled, then replace the tourniquet and leave in place until the patient goes to the OR. There is a low rate of associated complications with tourniquet use, and some of those would be due to prolonged use, nerve palsy, muscle necrosis, vascular thrombosis, acute kidney injury, which would be rhabdo, compartment syndrome, soft tissue damage, and amputation. The author of this article said that there was some studies that were done showing that local hypothermia can decrease muscle ischemia for prolonged tourniquet use, but I haven't ever really seen that used. Have you guys? No. It would be interesting to see if that would be something that I've never really seen it used, but I mean, maybe we're just getting those patients to the OR where they need to be quicker. So TXA, Matt said that you guys are starting to use this on the truck, so there's developing a protocol.
We've been using it for a while, but we're changing, we're making it more useful.
Okay, okay. So it's a synthetic version of the amino acid lysine. It inhibits the activation of plasmagen, which is responsible for dissolving clots. It demonstrates improved mortality, decreased use of blood products among trauma patients when given in the first 3 hours after the injury. The studies do not show any significant difference in 30-day mortality in the use of TXA versus no TXA, and that they suggested further research on that. The first dose is typically given over 10 minutes with a follow-up dose of 1 gram given over 8 hours. I'm not sure if that's your guys' protocol. And then I just wanted to quickly talk about a couple special populations when you're thinking about hemorrhage. So the pediatric trauma patient, hypovolemia is shock as a result of hemorrhage is the most common form of shock in peds patients. The initial compensatory mechanism is increased heart rate, which increases cardiac output. Tachycardia is followed by systemic vasoconstriction, resulting in delayed capillary refill, a weak distal pulses, and cool mottled extremities. When compensatory mechanisms are exhausted, decompensation is sudden and rapid. So they always say peds they'll truck on until they don't. When compensatory mechanism, we will watch for early signs of shock to intervene prior to decompensation. So those would be decreased skin perfusion, altered mental status, so remember your AVPU, tachycardia, and delayed capillary refill. Hypotension is a late sign and reflects greater than 30% of total blood volume loss and indicates severe compromise to organ perfusion. The geriatric trauma patients, so they have limited cardiac reserves and can lead to hypoperfusion and rapid deterioration without expected changes in vital signs or physiological responses. Remember that a lot of these patients are on beta blocker or on cardiac glucosides, and that can mask your assessment of tachycardia. So if you notice, that their heart rate's just always 60, they're probably on a beta blocker. A heart rate greater than 90 may indicate significant physiological stress and increase the risk of mortality. Orthostatic hypertension may result from loss of baroreceptor sensitivity, and they also have a reduction in total body water, which can increase their risk for dehydration. And then the pregnant trauma patient. So MVCs and penetrating traumas are responsible for the highest proportion of maternal deaths. These would be due to GSWs or stab wounds, which could be related to interpersonal violence or suicide. Pregnancy results in a hypervolemic or hyperdynamic state. So their total blood volume increases, so the maternal tolerance to hemorrhage is improved. A 30 to 40% loss of total blood volume can occur without a significant drop in blood pressure. Their resting heart rate increases 10 to 20 beats per minute to meet the increased metabolic demands. Patients with a heart rate greater than 100 should be assessed for shock. Increased hormonal levels from estrogen and progesterone cause vasodilation, so the pregnant patient in shock may appear warm and dry. In response to hemorrhage, catecholamine-mediated vasoconstriction of uterine vessels shunts blood away from the fetus to the mother. So fetal tachycardia or bradycardia or decreased fetal movement are evidence of fetal hypotension. And fetal hypertension can occur before signs of the maternal shock are apparent. Those are my references. And please call, email, get a hold of Matt if you guys ever have any questions or concerns, or if there's anything that I can help with, I'm happy to. I haven't had a chance to get out and meet a lot of people so far because of COVID and getting used to my new role. So I hope to meet you guys soon. And please just reach out if you have anything that I can help with. Thank you. Have a good night.
Are there any questions out there for Peggy or for Joe from the previous lecture?
One of the things I want to hit on for TXA is, there used to be in the protocols, both in the Cleveland area and here in Youngstown, is that, you had to be 15 minutes out from a trauma center. They had to present with signs and symptoms of active shock. the research is going in such a way that you don't have to have those active signs of shock or the 15 minutes out from a trauma center. In fact, the research is saying that if you have a significant injury, such as a fall from a tree, down the steps, a motorcycle ejection, those are significant injuries where you could go ahead and start the TXA quickly and get that infused over 10 minutes. So what both protocols say in the Cleveland area and here in Youngstown, and I'm sure it's similar throughout the region and even in the States, because this is what the guidelines say, is that you're going to take 1 gram and mix it into some pre-filled saline of either 50 mLs or 100 mLs, and you're going to drop it over 10 minutes in order to get that TXA in. So go ahead and make sure that you're giving the TXA. It works wonders, and people are benefiting from it. I know that Trumbull is a static when we give it. St. E's and the Youngstown area is a static. If you're in a trauma center up in Cleveland, Columbus, West Virginia, this and your protocol allows you to give it. This drug helps prevent the breakdown of the body's natural ability to clot. So how TXA works is your body starts to use up its clotting factors. And then the body realizes, oh, wait, I'm using my clotting factors. I don't need the clot as much as I think I do. And so the plasminogen is converted to plasmin, and it breaks down the fibrin, and then it disintegrates that clot. Well, what TXA does is it blocks that pathway so that your clots stay intact. So there's no form of, increased, causing a clot to happen or causing a brain clot or a stroke or a PE from the clotting mechanism. Your body's going to do what it needs to do, and this drug prevents the body's natural ability from breaking up that clot. Also, interesting enough, they also used to say that don't give it for pediatrics. Well, here at Trumbull, as we've already said, that we're pretty proactive. And also in the state of Ohio in 2021, they released the EMS guidelines and procedural manual for pediatrics. And right there under paramedic, it says for pediatrics, give TXA if you're a pediatric less than 12 years old, 15 milligrams per kilogram over 10 minutes with a max of 1 gram. And if you're a pediatric greater than 12 years old, we're going to treat it like an adult. We're going to do 1 gram over 10 minutes. So again, get this drug on quickly. If you feel that it's going to need to go to a trauma center, there's a reason, especially for hemorrhage loss. Get the drug in, infuse it, and use the other arm to do your pain medicine or your fluid resuscitation. So this would be the time that I would advocate for maybe 2 IVs. One, having your TXA running at over 10 minutes, and the other one for any fluid administration that you might give. And usually that's just to stay for an adult to maintain a systolic blood pressure right around 90 or so. So I just wanted to share that with you guys before Matt takes the stage here. But good stuff, and you can download that information from the EMS, State of Ohio EMS. It talks about the pediatric guidelines.
Thanks, Larry. You're always a wealth of information. Always stays up to date on stuff. Keeps us all on track. Appreciate it. Well, we're into the final leg. I'm going to be talking to you today about fluid resuscitation in EMS. I'm deliberately not going to pick apart every single little piece because we've been through a lot of this tonight and over the last couple of days. So if there's anything you need to discuss, any small details that you need to discuss as we go on, feel free to stop me. You can either put your hand up or when appropriate, you can just talk. So most of you know me. The rest of you have met me throughout the last couple of weeks. I'm Matt Gordon. I'm the director of EMS here at Trumbull. And this is my talk on fluid resuscitation. Anybody who knows me knows that my fluid resuscitation usually consists of something like this. If you give me a frozen creek somewhere out in the middle of nowhere, I'm as happy as can possibly be. So that's my kind of resuscitation. The cardiovascular system, again, these are all things we already know. The cardiovascular system requires a pump, vessels, and fluids to maintain pressure and to maintain perfusion. We always say that, the blood goes round and round, and the air goes in and out, and anything that changes that is a bad thing. So when too much blood goes out, or we lose too much fluid through any other way, we end up hypoperfused, which is, the definition is low BP due to a loss of fluids. When we are hypoperfused, the body compensates by increasing our systemic vascular resistance and our heart rate. So if this blood loss continues or a large amount is lost at once, we might not be able to compensate, like Peggy was showing you with the different stages of shock. And of course, if we fail to compensate, then we end up in a state of shock. So we've been constantly assessing shock over the years with our systolic blood pressure of 90. And that's just fine. It's a good rule of thumb. Most places are leaning towards a little lower blood pressure. We'll touch on that a little bit later in the lecture. Most places are concentrating on a little bit lower systolic blood pressure. But the best way to assess this is through mean arterial pressure. And we want to maintain that map above 60 to 65 millimeters of mercury, and that ensures organ perfusion. When we use systole, the heart's only in systole 1/3 of the time, so we're only assessing the function of 66% of the time of the heart. So that's why mean arterial pressure is going to be a little bit better way for us to assess what's going on systemically, which will guide our fluid resuscitation. Mean arterial pressure measures the average pressure put out to the major blood vessels. The normal value of systolic and diastolic pressure can vary widely. My resting blood pressure might be 110 over 60s. Larry's might be 180 over 90. So, you know, the systolic blood pressure might not be the most accurate measurement of what's going on with the body. The mean arterial pressure is going to give us the distance between those two. In other words, the pressure that the body has to pump against to get that fluid all the way to the end of the system to oxygenate and keep all of our cells alive. Nice thing is that most of our monitors have this feature on them now. And it is it's pretty darn accurate as far as our automatic blood pressure cuffs go. We always caution on our automatic blood pressure cuffs, you know, you always want to check up on them, but they've gotten a lot better over the years. I don't think I rely on them exclusively, but if I'm monitoring somebody and I've already got a good baseline blood pressure, you know, manually, I'm comfortable with the machine at that point to put it on and help you keep an eye on this mean arterial pressure. So if your machine doesn't have a mean arterial pressure window, it's time to do some math. We all love doing math in the back of an ambulance. This unfortunately isn't something that we can titrate to effect. Mean arterial pressure equals your diastolic blood pressure plus 1/3 of your systolic blood pressure minus the diastolic blood pressure. Everybody got that? Good. There'll be a test. So if we take a blood pressure of 120 over 80, which is the blood pressure that every new EMT gets on every call, right? We end up with a mean arterial pressure of 93.33. How do we get there? Well, 80 plus 1/3 of 120 minus 80. The 1/3 comes to 13.33 plus 80 equals 93.33. That keeps us above that 60 to 65. That's good perfusion right there, correct? That's the end. No. So when we find we have a bad mean arterial pressure, we've decided that our patient's in shock, and we're going to go ahead with some fluid resuscitation, we need to decide what fluid we're going to use. 99.99% of the time in EMS, obviously, it's going to be isotonic fluids, but we're going to just touch on hypertonic and hypotonic just so that we have an understanding. Hypertonic fluid has too much salt, and so the water leaves the cells and leaves them like those dried out little raisins under hypertonic. Hypotonic doesn't have enough solute in it, and so that the water is more apt to go into the cells to equalize the cell. We're not going to go over osmosis and osmotic pressure and everything like that, but this is just a quick refresher. I'm sure you've all seen this exact picture in your textbooks more than once. So isotonic crystalloids are what we use every day, right? It's a salt solution that contains electrolytes. Pretty much, what do you call it? Gatorade. And we use that to replenish extracellular fluid loss. But it's important to remember that only a quarter to 1/3 of that infused solution remains in the cardiovascular system. Some of it is going to leave that cardiovascular space, causing some edema and some interstitial edema that, when it gets too bad, is going to give us some difficulty transporting gases to the red blood cell. We're going to have a real hard time passing oxygen and taking off carbon dioxide. And the most common ones we use in this particular set is normal saline and Ringer's lactate. What about hypertonic? It's a more solute concentration than what's in the cells. So obviously what that's going to do is draw water out of the cells and into the vascular space. Many years ago, there was some theory that we were still so concentrated on blood pressure that the theory was we could draw even more fluids into the vascular space, but we were stealing it from somewhere where they really needed the water. So we might have a blood pressure, but we had a bunch of dead cells getting good pressurized saline. But they're very useful for increased intracranial pressure. That is not the insane clown posse, if anybody's wondering. Whoop, whoop. But it's most often used for increased intracranial pressure and for pulmonary edema. Most common is mannitol and 50% dextrose. What do we use 50% dextrose for? We're putting a hypertonic solution into our patient's arms when they're already compromised. That's one of the reasons why we've moved towards D10 and away from 50% dextrose, because hypertonic solutions are hard on the body and they're hard on the vasculature. Long term, it's not a good thing. So that's why we go with the D10. Synthetic colloids, they're out there. They cause huge fluid shifts. They're not generally used for resuscitation until later in the game. They have large molecules that stay in the vascular space, and like Joe was saying, it doesn't have to be a charged particle. It could just be a large particle that's going to draw water into the vascular space out of the cellular and interstitial space. These are used more to reduce pulmonary and cerebral edema, just like the other. And you hear about these all the time. These are albumin, dextran, plasma protein fraction, head of starch. There's a bunch out there. But you see that these, like plasma protein fraction, like Peggy was saying, may be used farther on down the line after the immediate resuscitation, to try and balance that fluid shift. Blood and blood products. They're not widely used in EMS. Due to the cost and storage issues, they'd probably be awesome if you could afford them, if you could afford and find a way to store them and use them appropriately. Is anybody out there, or anybody out in any of the systems that are on this call, anybody using blood products?
Hey Matt, it's Justin. Yeah, we're using packed cells and never frozen plasma.
Do you use those on your ground units or just on the air?
Just on air critical care.
Yeah, that's primarily the only place you're going to see it right now is blood and blood products is air medevacs. Sure would be nice to have sometimes, though, I imagine. So we have all these fluids and these different choices, and I'm going to take all the mystery out of it. The only choice we're going to use is isotonics. So how do we go about doing our fluid therapy? There's a lot of different shocks that we come across in EMS. How about spinal shock? Well, yeah, we're going to go ahead with some fluid therapy to try and gain that mean arterial pressure of 60 to 65. Most protocols say the 20 milliliter per kilogram boluses. We have to be really alert to fluid overload in spinal shock because, if they have phrenic nerve issues or anything along that line, their respiratory status might not be where it needs to be. So we need to be very careful of fluid overload in these patients. And honestly, our main way to gain our blood pressure back and to try and reel these people back out of decompensated shock is going to be through pressors. Cardiogenic shock. Again, no mystery, the fluid therapy to a mean arterial pressure of 60 to 65. When I'm talking about the mean arterial pressure of 60 to 65, if you don't have that, what you're still looking at your systolic blood pressure. But 90 is not necessarily that golden benchmark that it used to be. Maybe in cardiogenic shock you're looking for 90, but as we get on farther into trauma and whatnot, you're probably not going to be looking for that 90 or that 80. You might be looking for something less. Obviously, if you have a patient in cardiogenic shock, you need to monitor them very closely for the complications that come with that, for the fluid overload, for backing them up. Be very, very careful as you administer these boluses. And cardiogenic shock, they need meds, they need pressors, they need medically controlled. Septic shock. Septic shock kills a lot of people. We'll talk about septic shock later on in the program. There's some different theories in septic shock these days, though. Septic shock is one of those where we weren't too concerned with just pouring those fluids in. But of course, just like everything else in EMS, that might be changing. But for now, fluid therapy to that mean arterial pressure of 60 to 65, they need pressors, they need antibiotics is what they need. We need to fix the problem. One of the things that we are working on at Trumbull is pre-hospital antibiotics in the correct patients. So look for that to be coming in our protocol update. As soon as we iron out a few things, we'll be launching that program. We're very, very interested in getting these septic patients turned around as quickly as we can. If you do have a septic patient or a patient in SIRS, when you call in, please let them know that. Don't be afraid to call that sepsis alert. We have the ability to assess our patients correctly. Let's do it and get this alert. When you sound that alert, everything moves a lot quicker for this patient. So when EMS says it, we listen. Like I said, there's currently some studies of limited or no fluid administration for septic patients, with the theory that shunting from the extremities to the core organs and everything is exactly what the body needs. I don't know. Sounds risky to me, but like I've said before in these lectures, everything I learned in college turned out to be wrong. So we're not afraid to change what we have to change. That's why we run an evidence-based protocol. So when it's time to change, we're not afraid to change. Hemorrhagic shock. We just went over a whole bunch of hemorrhagic shock. You can pour all the fluids you want. I'll give you any fluids. You can give you whole blood, and you can keep pouring them in and pouring them in and pouring them in, but you have to stop the bleeding. You've got to stop it from going out before we can worry about what we put in. So in hemorrhagic shock, it is absolutely critical, important. The number one thing you need to do is stop the critical bleeding. Because it turns out, 214 gauge angios running wide open in bilateral ACs on the way to the hospital. We found out after a few years of doing that's bad. And bleeding is certainly a case where shock is good until it's bad. A lower blood pressure, a more concentrated blood volume, things like that are actually helping us stop bleeds, especially internal bleeds that we can't control by ourselves. And that's when TXA comes into play also. But we want to make sure that we're trying to control the bleeding, stop the bleeding. That's the key to hemorrhagic shock. Excessive fluids in hemorrhagic shock cause hemodilution. So we might have a decent blood pressure, but it's not carrying any oxygen. It's not carrying any nutrients. We're becoming more and more acidotic. Clot dislodgement. A clot that might have been holding in a mesenteric artery at 60 millimeters of mercury, and then we get their blood pressure up and we think we're doing something great, and we get them up to 90 and it blows that clot right out of there. So we need to be very cognizant of that. And excessive fluids contribute to cellular hypoxia by increasing the distance between the cells when this goes into the interstitial fluids and we can't get a good gas exchange. So that's why most places, including us, go with permissive hypotension. Hypotension's okay. Normalization of the BP is discouraged in hemorrhagic shock. 120/80 in hemorrhagic shock isn't a good thing. So we're laying off on the crystalloids a little bit. We want to be ready. I'm not telling you not to start IVs and give some fluids and everything. That's exactly what we want to do. But we're not flooding them anymore. We're not running those 214 gauges wide open and trying to get a blood pressure of 100 and all that. It doesn't even work. So we want to keep that systolic blood pressure maintained at 80 to 90 or a mean arterial pressure of 60 to 65. And there's a lot of studies on even lower BPs, especially in abdominal injuries and pelvic injuries, where a lot of places are okay with that blood pressure being as low as 60, because we want to be able, because we don't want to dislodge those clots. Because if you manage to stop bleeding in a pelvis, well, you didn't stop it. If the bleeding stops in a pelvis, you sure as heck don't want to start it up again. But let me be clear that a low blood pressure is not our goal. We're not trying to cause a low blood pressure. We're just making a compromise pending that surgical intervention. Hemorrhage control is our goal. We have to control the hemorrhage. It's not as important to get the fluids in as it is to stop the fluids from pouring out. A couple things that were in Peggy's talk is, if you noticed in class 2 shock, there were still normotensive, but the pulse pressure was narrowing. And then in class 3 shock, it wasn't until class 3 shock that the systolic BP starts to drop. So if there's 4 classes of shock and we're to the third class before that BP starts showing, that tells me that we should really be watching our mean arterial pressure and have a high level of suspicion for the hemorrhages that we're looking for. Burns. We don't work on a lot of burn patients. A burn is a trauma. We don't work on a lot of burn patients. Sometimes from house fires and everything, we do get them in home accidents, but they're a very dramatic patient. Most times they're not unconscious. They're usually yelling, screaming. It's visually, it can be very disturbing. And so it's very hard sometimes to just settle down and do what we need to do with a burn patient. But it's important that you do that. Burns get more fluid than any other shock. And we're going to go over a little bit of how we come up with those fluid numbers. Their shock, the shock in burns is a combination of hypovolemic and cellular shock, accompanied with a lot of microvascular and hemodynamic changes that don't happen in other shocks. Cellularly, there's serious issues. In addition to the local injury, there's a severe systemic response. Peggy touched on SIRS in trauma and in burn patients, and that's very true. Now, it sounds funny to say that they're going to have a inflammatory response to burns. Of course, they are going to have it locally, but we're going to show in a minute here that it happens globally, that the unburned cells are just as affected sometimes. The SIRS combined with vascular permeability and the inevitable fluid shift that comes from the burn patient leads to the edema, hypovolemia, and hemoconcentration. So the fluid has left the vascular space, but the cellular bodies aren't leaving the vascular space. So you have a very sludgy blood going on, a very concentrated blood in these patients. So our fluid therapy in a burn patient, our main objective is to maintain and preserve tissue perfusion. It's kind of our main objective in a lot of the things we do, isn't it? The initial resuscitation is based on crystalloids. because colloids used in the first 24 hours can pass into the extravascular space, which creates an oncotic effect and severe third spacing. So use of colloids is discouraged, and if they are used, they have to be very, very closely monitored. So in order to decide how much fluid we're going to give a burn patient, we have to be able to calculate burn percentage. This is not a burn percentage calculation talk. So we know about the rule of nines. We know how it changes with infants. We also know the rule of the palm. One thing that happens with the rule of the palm of your patient minus the digits is roughly 1% of the body. Be careful not to use your palm to judge the burn percentage of a body, because you know, a child's palm might be 3 or 4 or 5 of yours. So we would come up with a bad calculation. Historically, though, our estimates in EMS, no matter what system we use, are way off. I've read many different things that just we're way over, we're way under. It's a tough thing to do. Might be worth polishing up on. Maybe in the acute setting, in the first hour or so when we're doing it, it's probably not going to make that huge of a difference. But the difference of fluids that we're going to give to a person who's burned 18% of their body as opposed to 36% of their body is quite significant. So we want to try and be good at it. But like I said, it's not a class on calculating burn percentage or burn thicknesses for that matter. But we're all aware of the classifications of burn thicknesses. We like to change the names of them back and forth. This slide is terrible. You can't even tell what it says. But you know, first degree, second degree, third degree. Then we've gone with, you know, full thickness, partial thickness, whatever you're using. In the acute setting, a big bad burn is bad, right? I mean, that's correct. But we do want to try and get some numbers so that we can just guide our fluid therapy a little bit. Because the fluid therapy in burns is the amount of fluid is to be infused is directly proportional to the severity and the size of their injuries. In general, body surface burns over 20% is considered a major burn at most burn centers. A body surface area burned of over 30% is when you're going to experience systemic transmembrane decline in the burned and unburned cells. In other words, the unburned cells are going to start acting just like the burned cells as far as fluid shift. So you can see where the fluid shift is going to be major over the first 24, 48, 72 hours with the burn patient. Everybody remembers the Parkland burn formula, I'm sure. It's 4 milliliters times the total body surface area times the body weight in kilograms is the total amount. 50% of that's going to be given in the first 8 hours and 50% of that given over the next 16 hours. Everybody got that? Do that math in the back of the truck, right? So, but there's a little bit easier way for the EMS side. So let's look at the 75 kilogram female with burns over 20% of her body. So 4 milliliters times 20 times 75 equals 6,000 milliliters over 8 hours. Times 1/2 is what we're going to give or divided by 1/2, again, times 1/2 is what we're going to give in the first 8 hours. So we break that down, 3,000 milliliters in 8 hours brings us to 375 milliliters per hour, or 6.25 milliliters per minute. So we can also take a little more simplified approach, because we're not particularly concerned with the next 24 hours, right? We're concerned with not fluid overloading our patient on the front end. So if we can take instead of the original formula and break that down, so we want to deal with the first 8 hours, correct? So 4 divided by 8 hours is 0.25 milliliters. So that's what we're going to give in the first 8 hours. That's the percentage we want. Times body surface area times kilograms over 1 hour. And that brings us to the exact same answer. So take a look at that bottom row and see how much easier that is than doing the full Parkland-Burn formula. And that's a lot easier, and that comes from Wake Forest University. At this time, I want to know if anybody has any questions. It's 9:02. Does anybody have any questions on fluid resuscitation, on hemorrhage care, or on anything we've talked about today? Boy, these must not have been very good lectures today. No talks. That's all right. Either that or they were awesome and you got all the information you could possibly stand. I'd like you all to keep your eye out for the slide that's up right now. That's a survey that we're doing through Steward on our EMS and how we perform, and our EMS, our ER performs with EMS, and how I perform with EMS. If you have a minute, I'd appreciate if you would scan that and answer that poll. It only takes literally 3 minutes. So, still no questions, concerns, comments? Are you out there?
Still here.
All right,
No
just
questions.
checking. Okay. One thing I did want to mention. Peggy did bring up Stop the Bleed. Trumbull, we do go out and teach Stop the Bleed. I've been out to several of your places. We do a lot with the police departments. We've also supplied a lot of different EMS tactical units with our pouches and whatnot. If you need any assistance with Stop the Bleed or anything along those lines, please feel free to contact me, and we'll get you hooked up as quick as we can.
Hey, Matt, Don Hutchinson has his hand up.
Okay, go ahead, Chief.
You show that slide of the mean pressure? It's back there a ways. Nope, there it is.
I can't see the bottom of that slide, but
Can I give you a simpler way to do that? Old
I'd
math.
love it.
Systolic plus diastolic divided by 3.
Systolic plus diastolic divided by 3.
Yeah, and I just sat here and did it and come up to 93.33.
You would think you were like a perfusionist or something.
Well, it's just, that's pretty tough what you were showing there. I'm going, holy cow.
No, I agree wholeheartedly. No, I like your way better.
Yeah, because that's all.
Oh, thank you very much,
Chief,
man. Appreciate that.
Can you repeat that?
It's just the 3 cycles of the cardiac cycle: systolic, diastolic divided by 3.
Thank you.
Dynamite. Who else
So
has
if
any tips for me?
Just if you were using a regular cuff, that's, you didn't have a monitor to show.
Right.
And that makes sense too, because like with hemorrhagic shock, if you have a narrowing pulse pressure, your diastolic is going to be elevating. Even if your systolic remains the same, you're going to see that smaller mean arterial pressure. So it makes sense to go off of that versus your systolic. That's going to be a better indicator of decompensation.
Right. That's what we're leaning towards. Okay. Anybody else? All right, then I'll let you guys go. I'll leave this up in case anybody changes their mind over the next few minutes and has a question or anything. But I'll let you guys go, and we will see you back here Thursday at 6 o'clock. Thanks so much. I appreciate your time. Thank you, Joe and Larry and Peggy.